I don't know about you, but I'm still feeling the beat from
Oh my
yesterday,
gosh,
the silent
yeah.
disco. That was so much fun.
You know, it's amazing putting these headphones on. You instantly feel like a dancer. You feel like a rock star. Any inhibitions you'd ever had about dancing, it was on full display last night. And that is, you know, people come to NextMed and they know this community for the fun and games, and I'm so grateful that everybody brings their playful selves. Oh, by the way, good morning.
Good morning.
Good
yes,
morning.
I'm Dr. G, Dr. Gotham Gulati.
I'm Shauna Butler, nurse economist, and
Good morning to all of you.
The director for NextMed Health. And we were just still feeling all of the vibes and the dancing from the silent disco last night.
Yeah, that was a lot of fun.
But there's a really key piece of why we bring this into the experience. I have this phrase that I say, if you cannot sing and dance together, bring your best moves, be vulnerable and be willing to try, there is no way you can solve really hard healthcare problems. And what
People brought their best moves.
they did, and they had fun.
It was such a
and I
great
think
time.
that's, we talk so much about making sure that we bring the joy in medicine, the joy in healthcare, and man, there was so much joy last night. And we need more of that, and you need to bring your playful self. So that was definitely on display
I felt
last
like
night.
throughout these entire 4 days, there's been a theme of like how music is healing, right? And that's just
Yes.
a great,
How it changes your body, your
Yes.
brain, your behavior.
yeah, with the
And-
app and what Aloe Black was, is
Highway to Heal.
Highway to Heal. Yeah, it's great.
Yeah, so yesterday was really good. Any things that you heard that you wanted to share? Actually, we did want to say, all of our sessions are available for everyone to view. It's on the NextMed Health YouTube channel. So all of the sessions, all of these great talks, and we're so glad and grateful that you've joined us online. And if you've enjoyed watching all of that, we invite you to join us next year. Come and be a part of this community and make sure that you don't miss out on the silent disco.
Yeah, I mean, for me, I mean, the whole day was just really exciting. I got to, you know, of course, I delivered my talk early in the morning as well. So great conversations out of that. And then I got to sit here and actually have one-on-one conversations with a lot of folks. Like just, I mean, Alex Haddad and his daughter come in and they wrote this book, Healthy No Matter What.
And thinking about this toxic stress piece.
Yes.
And boy, do we have a lot of toxic stress. Her information and the experience that she's had as a young woman, starting companies, working with other founders, really looking at the challenges and also the really poor deteriorations in personal relationships, the personal costs and of being a founder, of having an early stage company. I thought that was a really important insight. So we want your company to succeed, but we want you and your relationships to succeed along with it.
Yes, and they just share these 8 different factors that sort of go into the toxic stress load. But what I like also about some of the thinking was it gives us sort of reason to step back a little bit, right?
Yeah.
They defining what is health and what is the meaning of health. Is it just all centered around sickness? And we've heard Daniel talk about we're in a sick care environment. Healthcare is sick care, not healthcare. And so it was just a good reframe, I felt.
And they're really easy points of connecting and talking about taking your shoes off, walking in the sand. And we did that last night, literally dancing, taking off shoes, and then walking outside barefoot, out on the grass, out in the sand. And it was rejuvenating. They were absolutely right.
Yeah.
So so kick off your shoes, go find
what
go
about
find
you?
some
What was
dirt.
your big highlight?
Well, when you brought up Alex, and he just has such a spirit about him. But seeing a father-daughter, seeing the mutual respect and admiration, seeing the generations, that was really, really powerful. There's so many different touch points. So don't ask me which one was my favorite. It's not fair.
But these are the types of connections that develop over here, right? Like Alex to me is like
Alex Haddad.
Alex Haddad. He's like my brother by choice is what he calls it, and just incredible human beings that we've all become family here, right? We all the hugs that went around yesterday were
we have forgotten social distancing. If there was, it's like it doesn't exist anymore.
So what's on schedule for today?
So this morning we've invited our friends from across the pond, Tony Young, who runs the Clinical Entrepreneurs Program at NHS, so the National Health Service in the UK. He's brought 3 of his, well, actually he's brought more, but up on stage, 3 clinicians who are solving really challenging problems that exist within society that show up in healthcare's door. And it is really interesting listening to the perspective that younger clinicians have. So they bring in the blend of, this is the lifestyle that I want, here's all of this education and process and practice that I understand people experience in healthcare. What things can be better? What things are fixed? And it's interesting listening. I mean, we hear so much about how all the challenges and the problems and the ways that healthcare systems in the U.S. are broken and under stress, feeling all that. And sometimes we will compare the U.S. outcomes and experiences to Canada, to our peer nations, to the NHS. There are a lot of things that are going much better in those places, but one of the things that he's going to talk about, there are some advantages to being in this national health service, this nationalized approach, but there are also some real challenges.
Yes.
And what he refers to, the beauty that they have there is that you can scale innovation there, but it's very hard for some of those breakthroughs. So, or maybe I have that backwards.
No, I think you've got, well, I mean, yeah, the pros and cons certainly exist. And I like this point that you brought up in terms of the perspective of young doctors. And we're sort of in a unique period.
Young clinicians, I want to be really clear about that.
Young clinicians, young health professionals, because we're somewhat in paradigm shifts that happen with these breakthrough innovations. We're sort of in a multi-generational state of health, right? So you've got the young clinicians, you've got those, like my age, who've seen sort of both the old world and the new world. And then you have the older folks, like my dad would have been, practicing this environment. And he hasn't seen, this whole new world is just is alien to him, right? So I think we see struggles around this in terms of engagement behaviors.
And I forget how many people are in this program now, how many clinicians, but it's over 1,000. And when I say clinicians, I want to name them. That's nurses, audiologists, dentists, anybody who is taking care of other humans in a healthcare setting.
Yes.
And by opening it up in clinicians, if he hadn't said clinicians, people wouldn't have felt like they were ready to dive in, or they were welcome, or that they were needed. And so that's why I'm very picky about that.
No, you should, and rightfully so, that's right.
Yeah.
Thank you for
So we've got that, and then we're going to be talking about diabetes, metabolism, and nutrition. So we have Robert Gabay, who is, he's the Chief Scientific and Medical Officer for the American Diabetes Association. And he's bringing on with him 3 folks who are innovating, thinking about what it is like life with diabetes, and that is, it is such a global, but particularly developed country problem, and it doesn't matter where you are, because we've seen there the diseases of affluence and diseases of where there is great resource. So with obesity rates rising in most places, along with that goes diabetes.
It is a huge crisis, not just here, but across.
And it's happening at younger and younger ages.
Yes, it's really scary, right? We're starting to see kids with pre-diabetes and diabetes. But I think also what's really central to these conversations around diabetes, which is rampant, is the notion of moving upstream and talking about the relevance of food as medicine and nutrition and the interventions. And we heard from like Nora Latour talking about Eat Real and starting at the kids' school level. So I'm really interested to see how we sort of move upstream to solve for diabetes. And
then we're going to be talking about from the hospital to the hospital. And Kevin Sneed, who is really helping us to think about how do we use our pharmacists and pharmacies. They're touch points in the community. It's key to so much of our health. It's also key to when we think about errors in our healthcare system. So many of these are pharmaceutically related. So how do we do it safer? How do we do it better? How do we move a lot of the friction? So Kevin's going to be talking about that.
I love how there's always these new terms that are created here at NextMed.
We have a whole new lexicon.
There's hospital, and then
I was going to say, I give credit to Zaina Kayat for that one.
And then Daniel yesterday talked about the intersection of the physical and the digital, called it the phygital.
Yeah, the phygital. So that's not for your 4-year-olds. And then Jeff Rutledge, who has a group of, I forget how many thousands of physicians that are part of HealthTap. So he's going to be up there, and he's going to bring up one of our Medi Award winners, Bill Chernick, who he was one of the winners for Medi Awards, which we didn't talk much about that, but man, the quality of startups. Paul Grand was talking about, he sees startups from all over the world, and the caliber and the preparedness and the conviction and the business models and their ability to present the problems that they're solving, the ways that they're solving it, the calls to action, the amount of life and dollars and efficiency that are saved when we solve very clear pain points in healthcare. So, Bill Chernick, he started Rocket Doctor, and so he's going to be up there on stage. And then we're going to close out. We're going to have Andrea Cates and David Ewing Duncan give us ahas and insights, what they heard, what they felt, what they've experienced. So we're so excited really from the standpoint of feeding the souls, the people who are really addressing, they're not afraid of the hard problems. They see how overwhelming they are, but they know, what are smart people for if not to solve the really grand challenges. So I like to talk about the NextMed community. It's filled with the smartest people on the planet who are solving the hardest problems for all the right reasons.
Oh, that's great. Yeah, that's absolutely.
So, yeah, Andrea Cates is going to set us up for, so now that you've got all of this, how do you get to your next? How do you get to your next? Because the future is too far away. We need nowists instead of futurists. So this has been so fun hosting this with you.
It has been such a blast.
And
Thank you.
I'm so grateful to our partners for Click
Yes.
Health, Carillon, CareQuest Innovation, all of the things that Pernuvo shared up on the stage about scans, and just people who understand that there are great needs out there, and there's a community of people who are prepared, willing, interested to help solve those problems, and so to have partners who are willing to, who see that mission and dive in and support that. It means the world.
And even though this is the last day of the event here on site, that doesn't mean the conversation has to stop. So don't forget, if you haven't done so already, follow us at NextMed Health, both on Instagram as well as Twitter. And even if you come across something, throughout the next week or next month or next year, just hashtag NextMed Health. Keep us in the conversation. Keep
and
the
like I said, if
going.
you've enjoyed being a part of this, join us here live next year, 2024. So I need to go run to the stage, and I know that our disco manager is waiting for these. There's a little bit overdue, but I had a great time dancing with you this week.
I loved it. Thank
you so much. All right. Thanks, guys.
Thank you, everyone.
Ladies and gentlemen, please welcome back to the stage Dr. Daniel Kraft and Shauna Butler.
Good morning.
Woo! We're so glad to see that some of you are still here. It was a very late, very fun night. You know what I love most is that you guys bring your playful selves.
I thought it was the skinny dipping that you liked the most.
Well,
There were some people who went in the ocean. Cake by the ocean, that's all I'm going to
Yeah,
say.
I was going to say, just remember what happens here at NextMed. Most of it goes out in the world, but there are a few things. What happens here stays here. So, how are you feeling this morning?
I'm ready for more silent disco. That was a lot of fun.
That was a lot of fun. How are you guys feeling? Good, 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 good. And if any of you are missing some glasses, and also out on the dance floor, somebody needs to have this earring back. So if you know who's missing those. I was going to say from the standpoint of how are you feeling energetically?
Energetically, it's hard to believe this is day 4. Yeah.
I know.
Yeah.
And what
We didn't have enough content. We're really sorry about that. Next year we'll do a little bit more.
More,
Yeah.
yeah. What's now near and more.
Definitely.
So we have a microphone there in the center because part of what we wanted to start out with this morning is just to get some of your thoughts, what your aha moments, your insights. what you want to see more of. We'd love to. So that microphone is there. You guys are not shy, so please step up there.
Yeah, it could be an idea that sparked, somebody you met, something happened in the innovation lab, anything that...
What have you cherished or treasured?
Yes, we're all shy. Someone step up.
Yeah.
So there's something that...
And by the way, I was going to say good morning to our online audience. We really appreciate you guys joining us, staying with us, tweeting at us, posting. We have had some really interesting, some of the best feedback we get, or summations, are you guys here in the audience and our online audience writing up what they heard, what they felt, what they experienced, what they're inspired by, what they're catalyzed to do. We've seen some amazing write-ups.
And we'll share later a bit of a crowdsourced document where some of the folks here have been kind of taking furious notes, taking pictures, putting it all together. It's a lot of insights and ahas and sparks, so hopefully those of you who want to contribute to that can as well.
Yeah. Anybody want to share anything? Yeah. I was going to say, there are no not brave souls here.
I'll jump up here and say something. No, it's been an amazing few days. Thank you so much for all the work that's gone into putting this on. I know just putting on a few conferences myself, I know just how much work it takes. Would love to see kind of like a social board, a tweet board, kind of seeing all these ideas in this room, kind of achieving escape velocity out in the metaverse. I know a lot of people are online, and I love that you're streaming this, and it would be great to see the ideas out there.
Great, thank you. If you could introduce yourself also.
Hi there, my name is Ryan Douglas. I got a chance to speak with you guys the other day, and I'm alum as a participant from 13 to 15, I think 2015. This has always been an amazing opportunity for me. I'm so grateful this is back. Again, just a convergence of amazing folks and new ideas, and I'm excited to go out and make some new things. Thanks, guys, a lot.
Great.
How many, wait, last time you left, you wrote like 5 patents. How many this time?
Well, Paul and I were just talking about that, and I think we just came up with 2 or 3 things we're going to do together. So we're going to, I think probably we'll walk out of here and write 3 in the next couple of weeks, is what
Awesome.
I expect.
And by the way, one thing we want the community to do is cross-connect on how to amplify ideas.
Yeah.
You have a process for doing intellectual property. Maybe we could share that out later, or...
Absolutely. Would love to show you how that's going on. So we've put together a patent suite at the moment, and it works. So our busiest professionals with their greatest ideas, they come in with bullet points. They speak live. The AI works in real time. We can pull up the other patents, existing prior art. We have an artist working, and so we'll put together a provisional, and with our crew in about 4 to 6 hours, we file within 24 hours on new concepts, and the principal inventors really only need to show up with their concepts, their ideas, and the research they've done. And so that's led to, in the case of Deepwell, in 18 months, we've filed 14 patents with some amazing folks. So it's a really, Thompson Patent Law is the one that put it together. Craig Thompson is an amazing patent attorney, and he's someone you should look into if you're an innovator. And if you're looking for someone that understands when you're in that innovation mode, you're not flush with cash. It's the most expensive money you're going to have. He gets that. That's why he built this suite, to be really efficient.
So let's share that out, and also ways to cross-connect. Maybe we're going to create a WhatsApp group. One of the things we want to crowdsource here is how do we keep the NextMed Health community live and online together?
We got 3 more of you guys.
Right.
So
Thanks.
Mr. Canada, who has no fear of the cold, please,
Nice choice.
Mr. Canada, who has no fear of the cold. Hey, it's Mario, Canadian physician. Huge fan of this event, guys. I've been coming since 2013. It's funny, the last time I was here, 2019, I was talking to Will Wiseman about how a membership, a lifetime membership would be something that I would be interested in, just because this venue is like a spiritual home. A lot of us are in our own silos. We're independently working hard, trailblazing, doing our own thing, and it's just amazing to be with other folks who are chasing their problems and solving them and working towards the betterment of healthcare. And it's just amazing to be always in an amazing group like NextMed Health. So,
thank you.
So you're a charter member. Who else wants to join?
Yeah, lifetime.
All right, we're signing you all up. Awesome.
Okay.
There you go.
Thanks.
All right, 2 more, and if we can wrap.
Yeah, hi, Andrew Vincent, Atta Caribbean and Integra Healthcare. It seems like the last few years that we've been always on the cusp of just a wave of new technology and connected technology, and actually this time it really feels like it is here.
It is.
But to me, it reinforces now, I think, the really important interoperability and the connection into the EHR systems, because all of a sudden we could find ourselves with 1,000 devices to deploy and no way of handling the data if we're not careful. So, you know, that's a call to all the people forming it, is we've really got to get together and actually get all that joined together so it works.
Yeah.
It's all about the workflow, and I heard ChatGPT 4 got launched today. Is this true? Yeah. Yesterday. So don't blink.
As Martin Luther King has always said, once said, the urgency, the fierce urgency of now. So.
I'll be quick. Nehal Mehta, academic cardiologist for 20 years, first NextMed. I am struck by the energy in this room, the amount of brain power that comes together, and the generosity. I'm a new founder and CEO of a biotech company 7 months ago, and the amount of you folks that just came together and started talking to me about who you can introduce me to and what we can do is awesome. So yeah, I'd be a lifetime member as well.
Great.
So thank you.
All right, with that,
we have a plan.
We have a plan. We now know what's next. Lifetime membership. With that, let's go ahead and kick off our final day. And again, thank you so much for all of your attention and energy.
Right. Thanks, Shauna. So what's interesting here, just as mentioned, we want to not just have technologies and fancy, shiny objects, but get them into the workflow, whether it's the EHR and other modalities for the patient, clinician, healthcare system. And we've been lucky to have Tony Young as a member of our tribe, I think since 2013, 2012.
At least, yeah.
And Tony is an amazing clinician and entrepreneur himself out of the NHS, across the pond in England, where I was born.
He sounds so much smarter than all the rest of us.
Everything sounds better in British. As Tony will share, his journey and amplification, scaling clinicians as entrepreneurs to scale impact is really impressive, and something I'm really proud to have been a small part of with our endeavors over the last few years. So let's give it up for the amazing Tony Young, and he's going to bring out some of his clinician entrepreneurs to follow. Tony.
Thank you so much, Daniel. So good morning, everyone. It's great to be back. As Daniel said, I came first in 2013 here and have visited about 4 times since. And one of the things I come away with every time is that we're very reserved in England, and you get this real can-do attitude in the United States. And I hope you're going to see in what I'm going to tell you some of the progress we've made. So I'm still a practicing urological surgeon, so kidneys, prostates, bladders, that kind of thing in Essex. I'm also a medical director in my hospital group responsible for innovation, research and transformation. I'm an academic too at my local university, Anglia-Ruskin University, and really where I lead innovation and enterprise. And that's really because alongside my PhD and surgical training, I did 4 startups, raised £5 million and exited them all. Some were amazing successes and some were total disasters. But I survived them. Now, in England, that was really unusual for a clinician to do that, but in the United States, it was fairly commonplace. And then 10 years ago, Sir Bruce Keogh, who was the National Medical Director for the Health Service in England, invited me to come and take on this new role of National Clinical Director for Innovation. So the first time that I'm aware of a nation had taken a clinician and put them in a leadership role for a whole nation's healthcare innovation. And one of the reasons he wanted me to do that, he said, we need you to help us address the inequalities, get the latest, greatest things taken up across our nation. We want you to grow the life science economy in the UK. We want you to become our senior clinical advisor, not just across the NHS, but government ministries, arm's length bodies, public sector, private sector, and foreign governments that came to see us about healthcare and life science innovation. And the last thing Sir Bruce said to me was, he said, Tony, we just want you to make the NHS the go-to place on the planet for healthcare innovation, but you've got no money and no power, so go and see what you can do. And if any of you have been to the NHS, you'll know that's exactly how we work. Now, that sounds like a huge problem, doesn't it? How are you going to make what is turning 75 years this July, the world's first universal healthcare system and the world's oldest one, how are we going to take that and turn it into the most innovative one? It sounds like a huge problem, doesn't it? And this is another huge problem. This is Jean-Simon Bartholomew's 18th century painting of what was thought to be the most intractable problem in ancient history. which is the Gordian knot. So it was a knot nearly 2,000 years ago that was so tight that no one could untie it. So Alexander the Great came to that town, took out his sword and just sliced through the knot, cutting it open. No one had told him you couldn't cut it with your sword. You were meant to untie it. So he brought new thinking and new action to a problem that everyone said couldn't be solved. Doesn't it feel like that in healthcare sometimes at the moment? So in the National Health Service, we would have a number of issues that I would say are our Gordian knot, our problems that people think are too difficult to be solved. And more of the same's not going to do it, and that's why I like coming to NextMed, because you meet new people, new ideas, new approaches, new ways of doing things. And if you want to work with the National Health Service, it's no good coming along to me and saying, we've got this great solution, why don't you buy 100,000 of them? You're a big healthcare system. That doesn't work. You need to understand our challenges, the issues we're facing. In our workforce, we are the 5th largest employer on the planet, 1.4 million people, and yet we have a 10% vacancy rate right across our system, 140,000 full-time vacancies. Reboot and recovery. Before the pandemic, we had a waiting list. After it, nearly 7 million people are on the waiting list for outpatient and inpatient treatment. And yet we spend, I think last year, £156 billion. How can we use that money to get patients seen and treated quicker? Health inequalities, we've heard about it this week on this stage, haven't we? Laid bare by the pandemic. We need to get serious about sorting that out. Net zero. The NHS has stepped forward as the first healthcare system in the world to produce a national plan. We will reach net zero by 2040 and all our supply chains by 2045. So if you want to sell to the National Health Service, the world's largest single payer of healthcare in 2045, your company has to be net zero in all its supply chains. So we've stepped forward and said that's serious. Long-term plan, and this was a document we published a few years ago, looking at how can we have excellent healthcare from cradle right through to old age, where patients are empowered to live healthier, more productive lives. And then the last challenge is cost efficiency. When I first came in 2013, everyone said, it's terrible, Tony. He said, we spent $2.7 trillion this year on healthcare. It can't carry on growing. I think this year you spent $4 trillion, 10 years later, and yet life expectancy in the United States is starting to go down, so you're spending more money and not getting the return. So we need not just to do things differently, we need to do different things. We can't carry on doing more of the same. So in NHS England, I sit in an organisation known as the Accelerated Access Collaborative. Now, I could spend the whole talk talking about that and the great programmes we have, some of which are listed up here, but I'm going to focus on one of those programmes today, because I brought some of our entrepreneurs with us. Now, when I first came here in 2013, I just thought, how can I, what Daniel was saying earlier, how can I bottle some of what goes on here, some of what you see and learn? How can I take it back to the National Health Service and give us that can-do American approach and enthusiasm? And so, as someone who'd been an entrepreneur in the NHS, and I felt when I came over here, I felt there are lots of entrepreneurs in healthcare. I was on my own in England, almost. There were 2 or 3 of us, perhaps. So we founded something called the NHS Clinical Entrepreneur Programme. And that was a program that would provide education and training, less than full-time if you wanted to take time out of your training. Commercial mentors, we have over 250 world-leading mentors. We connect them into customers and funding. We help support them with testing and trialing, networking events and industry days. And rather than hear from me what the program is about, I thought I would let you hear it from them.
The programme is a really brilliant way to tap into the healthcare innovation ecosystem and to open up a whole world of opportunities for you and your projects.
There's a work plan programme, you get to meet great people, and you belong to the family of clinical entrepreneurs. This is brilliant.
You're meeting your tribe. These are people who have the energy of being innovators, also to meet some amazing contacts and networking, and just to be exposed to some globally relevant companies.
I think one of my favourite moments on the programme so far has been presenting to the Medical Advisory Group and the CEO of the NHS, Amanda Pritchard.
Being directors, be it midwives, doctors, physiotherapists, people that I would have never have been able to be in front of.
At every pit stop, I've always come away with some surprise, connection.
Without the clinical entrepreneurship programme, I never would have got this idea off the ground.
Gained lots of business skills, pitching practice.
Support, advice, experience, questioning, coaching and a strategy.
The opportunity to think about how you can get your innovation into the NHS.
The mentor scheme has been absolutely phenomenal. To go from not wanting to stand up and present to standing up in a room full of several hundred people and doing a presentation that I enjoyed.
Everybody's really there to help you, support you and encourage each other.
Don't even think twice about it, just do it. It's an amazing community, amazing place where an idea, far-fetched idea by two young, naive medical students can become a funded reality.
See what happens when you come to NextMed, a program like this starts. So let me give you some of the reasons to believe. Sounds great, doesn't it? So MediShout is a company founded by an orthopedic trainee. He's raised £5 million now. What does it do? It unifies your help desks in a hospital. So whether that's facilities, stock and ordering, IT, medications, instead of having to hang on the phone and say, you're number 5 in the queue, we're really busy, we will answer you shortly. You photograph it, you type a little message into the app. Through AI, it works out what it is and it automatically sends it to the right department and gets that sorted. In my hospital trust, there are 16,000 employees, 11,000 have downloaded and regularly used the app, and last year they sent 100,000 shouts through this to the various help desks, meaning they don't have to hang on the phone. You heard from Hamid a moment ago. This is the Rainbow Drone Squadron. Green battery-operated drones that can fly around 70 kilometers, fixed wing. We had a dream. And our dream was, could we create a national air grid in England for autonomous drone logistics so that every hospital has a drone port transporting samples, medical devices, chemotherapy, drugs and other things. And everyone said, you'll never make it happen. This is England. You can't do this. So let's see what the chief executive of the National Health Service, Amanda Pritchard, had to say about it.
Delivering chemo by drone is just another example of how the NHS will stop at nothing to ensure that patients with cancer get the treatment they need as promptly as possible, while also, in this case, cutting costs and carbon emissions. The NHS has always been at the forefront of medical innovation. It's clear the pace of change and improvement is only accelerating as our fantastic staff seek to make the most of life-changing advances to improve patients' lives.
So Amanda has over £150 billion in her budget each year, which is quite a good budget to have. So that drone flight took place between Portsmouth Hospital and the Isle of Wight, where patients have to travel to the mainland for their chemotherapy because you can't get it there in time because the chemotherapy will decay once it's been prepared. It takes 20 minutes in drone flight. So we're now undertaking trials to see that we can get that launched. We're in Northumbria as well, delivering medical supplies in remote areas up there. So we can make it happen. UK satellites and ground-based beacons are going to be autonomously controlling this. We're not going to get it all done this year or next, but that's the destination of travel. Wow, next, Rachel Grimaldi, incredible, an anaesthetic registrar who, when she was looking after patients ventilated with COVID, they were awake, but they couldn't communicate. So she would write down standard medical phrases on a little pad, show it to the patients, and then give them a list of possible options. They could point to it, but they just couldn't talk to her. And thus, Card Medic was formed. And what Rachel realized was that it's not just people who are intubated, it's people whose first language isn't English. So now, Rachel's just raised over £1 million for her startup. The Card Medic app and platform allows you to speak to someone in any language, pre-translated medical phrases. You can pick them from a menu. So as a urologist, I ask about 6 questions generally. So they're all there, and the range of responses that a patient can select. So I don't have to wait for the translator. I can start to get that medical information straight away. Incredible. Timber Health, Chris Ramdu, wow, amazing. I think the world's leading smartphone otoscope. Done a deal with the Boots Walgreens Alliance now. It's in every Boots hearing test center in the United Kingdom. It's just expanding in Walgreens now, so you can have your ears examined by a technician in a hearing center. They can remove the earwax and you can have your hearing aid fitted immediately. 250,000 people have already had this service in the UK and the United States. They've videoed every single one. It's been analyzed by AI. Not a single episode of trauma to the eardrum. How incredible is that? Amazing. Now you're in for a treat. Proximi, Nadine Hashashharam, who's been to speak at this event. This is what she's doing. Incredible.
Imagine a global network of borderless, digitally connected operating rooms, brimming with the world's best surgeons. Intelligent operating rooms, unburdened by geography or time, where every single interaction is recorded, connected, reviewed, and stored to shape and improve best practice. A digital continuum of surgical expertise designed to reduce variation in care. Every touch, sound, piece of technology, every patient outcome. The paradigm of surgery and healthcare is changing. It is being reimagined by the operating system of the operating room. Proximi is a centralized platform designed to scale expertise beyond the 4 walls of an operating room. This once analog environment is now a digitally connected and data-driven operating system designed to improve global healthcare, creating a platform that brings the best surgeons, AI technologies, and application partners into any operating room around the world. Connected surgical care.
How amazing is that? Nadine is a full-time consultant plastic surgeon at Guy's and St Thomas's Hospital in London, has just raised £80 million to digitize everything we do in the operating theatre. Just incredible. This next one, Saif Ahmed, wow, an oncologist from Addenbrooke's Hospital in Cambridge, the world's first point-of-care diagnostic for neutrophils. Neutropenic sepsis, 50,000 patients each year who are on chemotherapy are admitted to NHS hospitals with suspected neutropenic sepsis. Single finger prick of blood in this lateral flow test allows you to tell if someone's got no white cells, normal or high, so you can start their treatment early. So quickly, some of the companies we've been through. In our first year, when I was told it wasn't, I presented here in 2015, said we're going to start this program, about 40 companies. Year 2, here we go, about 50 or 60 companies. Year 3, moving up to nearly 70 companies. Year 4, I think we got to 80 companies on that slide, and now I can't fit the companies on the slides. There are so many. So there's just one slide to tell you our data. In 6 years, we have created 423 new life science companies. That is 8% of the UK life science industry from a program from the NHS that I co-designed when I came here and met Daniel Kraft 10 years ago. How amazing is that? They have benefited over 130 million patients and professionals and users through their innovations. We now have over 1,000 clinical entrepreneurs on our program, making it the world's largest entrepreneurial training program in healthcare and life science. And between them, in their first 6 years, they raised over $1 billion in funding. So the first unicorn to arise from the Clinical Entrepreneur Program is the Clinical Entrepreneur Program and all our amazing startups. I always said we could do it, and we have. But actually, I wanted to show you, save till last, what I think the greatest innovation in healthcare is. I think it's the best. I see 2,000 new innovations a year in my role at NHS, saying that this is the greatest thing. I think it is. I'll see what you think. We've seen loads of great tech here. I don't think anything beats what I'm about to show you. And that is the healthcare workforce. That is this year's cohort of our clinical entrepreneurs on the stairs at the Royal Institution 3 weeks ago in central London. There's the statue of Michael Faraday. This is the place where electromagnetic induction was discovered and demonstrated to the world. And much like NextMed, our entrepreneurs 3 weeks ago pitched at our big event there. And I would argue that it's actually our workforce, our healthcare staff, who utilize all that great technology, who put it into the clinical pathways, are in fact the greatest innovation, human beings in what we're doing. So they are so great and so good. Rather than just me show you some slides, I thought I'd better bring some human slides with me. So I have 4 of our clinical entrepreneurs who they haven't ever pitched on a stage in America before, so this is going to be a new experience. In America, you teach people to pitch from when they're toddlers, I think. You're really good at it. So guys, do you want to come out and come and join me on the stage now? So we have Ben, Stephanie, Malone, and Ahmed, all who have different. Now, in England, I time them, and I then clap them if they overspeak their time. But they were all a bit apprehensive today, so I've given them 2 minutes, and they're going to tell you about their startups and what they do. We'll start with you, Ben.
Thank you. Hi, guys. So in a time where we're spending over $4 trillion now in healthcare, we cannot afford the 1 in 4 patients who no-show to their hospital appointments, costing the US healthcare system $150 billion a year. But that's 1 in 4 patients who can't access care when they need to. And the question we should be asking is why? So my name's Ben. I'm the co-founder and co-CEO of Deep Medical. And at Deep Medical, we created a cutting-edge solution which harnesses the power of AI to find out who's at risk of no-show 2 weeks before their appointment with 90% accuracy. And it's so much more than just forgetting and reminding. Actually, what we're starting to unpick here are the underlying inequalities in our society that are resulting in people not turning up. So it's the elderly man who's too scared to travel during rush hour traffic. It's your single mother who can't afford to take time off work. It's your immigrant family who might not understand the complexities about what is being written in them in their letters. So what we do at Deep Medical is we give the who, the why, and the what, so hospital staff can do what they do best, connect. We've been live now across 1.2 million appointments a year, where we're reducing their no-show rates by 50% in the first 2 weeks. So what I have to ask from you is to help us scale this product out into the US and actually deliver equitable access to care. Thank you.
Brilliant. Thank you, Ben. You can have a seat now. Incredible. I told you the wait list, up to 7 million people, 80% are waiting for outpatients. That's 5.6 million. Ben's startup on its own can identify the spare capacity and fill, if this works, he'll fill every one of those. How incredible is that? What difference to patient care is that going to make? Amazing. Stephanie, beat that.
No pressure. Okay. So my name is Dr. Stephanie Campbell, and I believe that everyone deserves access to great eye care. So what is great eye care? Well, I think it's 3 key things. The first one is early diagnosis. The second one is prompt treatment when you need it. And the third one is truly excellent communication. And as an eye professional myself, I haven't always been able to give that, and I desperately wanted to every single patient. In fact, I got tired and I got fed up of explaining to patients that they had irreversible sight loss simply because they'd waited too long to be seen. And that was really heartbreaking for the patient. It was really heartbreaking for me. And this was within a fantastic system with excellent drugs, excellent doctors, excellent teams. But it doesn't matter what amazing surgeries and what amazing drugs we have if we can't get it to the right patient at exactly the right time. And so that's why I set up Oco Health. in order to allow remote patient monitoring in ophthalmology. Because the problem wasn't that we don't have great service and great care, the problem was the monitoring was all happening in the hospital. And patients don't deteriorate at hospital, they deteriorate at home. So Occo Health is a very simple software medical device on a smartphone that monitors eyesight. But we're not talking about an eye chart on a phone, no. We're talking about simple video games, no letters, no eye charts, and these very, very simple video games that take 5 minutes 3 times a week collect brand new sets of big data about how we see. And by looking at that over time, we're able to detect deterioration early. And we're able to get people to the doctor to be seen promptly for treatment. And patients say it makes them feel in control of their eye disease because they can self-monitor, and it gives them the confidence to have meaningful conversations. So speaking about meaningful conversations, I've met incredible people here this week, but if you think we need to have a meaningful conversation ahead of my Series A next year, there may be some room this year, I'd love to speak to you. And if you think this technology could change your world as well, please let me know. Thank you.
Thank you very much, Stephanie. So, great pitch, but you were 30 seconds over. I gave you 2 minutes. Malone, I'm going to be a bit tougher on you.
Right,
so, Ben, first raise £3 million. Stephanie has raised about £3 million. Malone is yet to raise, so his earlier stage. But you don't have to raise £1 million to change 1 million lives. And what he is doing is amazing. Malone.
All right. Good morning, America. I wanted to start by asking the audience a quick question. Could you please raise your hands if you know what meningitis looks like? And could you keep your hands raised if you know what meningitis looks like on darker skin? Almost everyone's hands went down. So this was something that I noticed when I was at medical school. A lot of the time we were being taught how to identify signs and symptoms from the perspective of white skin. But I would sit there in the lecture theatre and ask myself, if I had that same condition, what would it look like on me? And I would often ask the professors, the doctors, the physicians, what does this look like on darker skin? And no one could give me an accurate answer. However, everyone could give me an answer of what meningitis looks like on white skin. So I decided to take matters into my own hands and create a handbook on this. It's called Mind the Gap, a clinical handbook of signs and symptoms on darker skin. Since launch in August 2020, the book has been read over 500,000 times in more than 75% of countries globally. And California is actually one of the leading regions in the world. This has been featured in Forbes, Time, and the Washington Post. And through the experience of writing that book, it allowed me to see that actually the problems for Black and people of color in the healthcare system are a lot deeper than we think. At the moment in the UK, there are statistics such as Black women being 5 times more likely to die during childbirth. And unfortunately, at the moment, people don't trust the healthcare system. So what I'm working on is building a telehealth solution which allows Black and people of color to have somewhere they can trust, to have a healthcare service that they can engage in. And my ask from everyone in the crowd today is if anyone is looking to be an advisor or technical roles in our team, would love to speak to you. I think race relations in the US are a lot more advanced and we can learn a lot from different people in the room. So thank you very much.
Brilliant. Thank you, Malone. Go and have a seat. He's a medical student. How amazing is that? I'm the National Director for Innovation for the world's largest healthcare system. I'm never going to solve that problem. But Mike Malone, if we can empower him to do it, do you know, I think he just might. Ahmed, 2 minutes, sir.
Okay. Good morning, everyone. My name is Dr. Ahmed Wobi. I have a background in neuroscience from Oxford University, where I studied movement disorders through deep brain stimulation, and then I worked as a clinician in the NHS for 7 years before I founded Tonus. At Tonus, we want to keep people moving better for longer. We know people are living longer, but are they living better? Are they moving better? When people get to the age of 50, we've lost about 10% of our muscle bulk, and for every decade subsequently, we lose 15% of our strength and our power. This is a really powerful statistic, but we haven't been able to fix this, and people are not being able to be empowered for a way to control this. So what we're going to do at Tonus is support people with tailored longevity performance apparel, and we are the only wearable that does this. Our sensor fusion technology is able to track the movement of your joints, your muscles, and your limbs, and combined with our AI interface and our machine learning algorithm, we can give personalized feedback and insights. And these biomechanic kinematic markers allow us to see into disease prediction, injury injury prevention and modification. One of the things we're looking at is powered movement. And you can do this through exoskeletons, so soft exoskeletons and artificial muscles. You've heard of an electric bike. Well, Tonus is going to bring you the electric hike. And one of the things that we think is that everyone needs a unique, personalized, tailored solution. So at Tonus, we've done studies where we used 50 patients, and we got them to go through multiple exercise activities. We collected over 12,500 individual exercise movements, and this led to millions of data points that we were able to validate the technology in comparison to a motion capture lab, with the benefit of being able to be used anywhere at any time. So currently, we have a fundraising round open, so our ask is to look for any investors and any collaborators that would like to deploy our technology in pilots going forward. So yeah, if you think like us that people should be able to keep moving better for longer, we'd love to have a chat with you. Thank you.
Great, Ahmed. Have a seat. Well done. So I don't pick winners. I'm not Elon Musk. I can't do that. What we do is we provide a culture, an environment in which people who dream, people who desire something better, who want to create something, who want the autonomy to do that, we give them a safe space to learn, to test, and to trial, and to grow. I have 1,075 of these. This is about 0.6% of my program. Imagine what that's like. Imagine what you could do in healthcare at scale. So what I thought I would do now is, because these are the people on the front line, why should you in America be interested in coming and bringing your technology, your ideas, your problems that you've faced and solved to the National Health Service? Because we want you to do that. So I'm going to have I'm a bit nervous about this, I'm going to have a very open conversation about the good, the bad, and the ugly with our startups, of how they're getting on in the NHS, what's good about it, and what's perhaps not so good about it. So first question we'll start with is, so the NHS, it is turning 75 this year in July, and despite being free at the point of care for everyone, there are still healthcare inequalities right across our system, and it's really important with innovation that we tackle at the start those healthcare inequalities. What are you doing in your innovation in the NHS to address healthcare inequalities? Ben, do you want to start with that?
Thanks, Tony. So, if you have a long-term condition and you miss 2 of your appointments, your all-cause mortality goes up 8-fold. That means you're 8 times more likely to die than the other patient. If you've got diabetes and you miss an appointment, your HbA1c goes up by 30%, on average about 7 millimolar. And if you have breast screening, a breast screening appointment, not turning up to that increases your chances of having a stage 3 and 4 breast cancer by 100%. So what we're doing is we've done research with those demographics who are at risk of no-show. And we found out, was it education? Because I keep hearing education is the problem. And actually, over 70% of the people that we interviewed, which were 200 in total, said that it wasn't education that was their problem. It was because they couldn't take time off work. So what we started to do was actually reserve those high-value times in the weekends, in the evenings, for those patients from these demographics, so that they can get those appointments first, and then to actually think, well, if there's still no showing, we reach out, and if they still don't respond, we bring somebody else in and get them off the list. So that's how we view equity and access, and we're challenging that.
Good, that's good. Malone, I'm not going to ask all of you each question. Do you want to answer that really quickly? What are you doing in healthcare inequalities?
I think for us, it's about building with a lot of intentionality. Like I mentioned, black women are 5 times more likely to die during childbirth. And there's also other statistics, such as you being 100% more likely to have stage 4 breast cancer when you show up on arrival at the clinic. For us, it's building with the community in mind, asking them what are the reasons why they don't trust certain things, and building with that in mind. So just making sure that we're building with the community.
Yeah, no, I think that's really good. And do you know, we've opened up, we didn't call it the Doctor Entrepreneur Program when we started. I was committed to calling it the Clinical Entrepreneur Program because I wanted nurses and allied health practitioners, dentists and pharmacists and clinical scientists to join us. Malone's mentioned a shocking statistic. If you are a black woman in our country and you're pregnant, you are 5 times more likely to die in childbirth than you are if you're white. That's a shocking statistic, and we have to deal with it. Not a single doctor on our program stepped forward to deal with that. This year, 3 midwives have stepped forward with separate startups to do that. So if we didn't have them on our program, we wouldn't be helping to tackle this issue. So that's really amazing. Right, next question. So the NHS has one of the world's largest healthcare data sets. And you may have seen a few weeks ago we announced we're spending £250 million to create a federated data platform, the pipework that joins all that data up. In my view, it will become the world's leading and most accessible live learning healthcare data set. So this is a great opportunity. How are some of you using that data in your innovation? Because it's one of our advantages in the NHS. Stephanie, how are you using data in yours?
We're working with 2 of the leading teaching hospitals, huge teaching hospitals, who have a very high throughput macular degeneration service. And we're using those very standardized encounters because they're such big systems. They have very standardized protocols. The patients aren't on 100 different treatment regimens. And what that means is that we can get high quality tagged longitudinal data from those so that we can get good ground truth for the AI that we're developing. So I don't think, there's any better place to do that than the NHS.
So in the pandemic, every single intensive care unit in the United Kingdom shared their research data. We led the world in research trials in COVID as we joined our data sets up. We discovered dexamethasone. We disproved hydroxychloroquine and a variety of other things that came forward. It's really powerful, and that's what our entrepreneurs have access to. Ahmed, how are you using data and access to it in the NHS in what you're doing?
So in a similar way to Stephanie, we've seen the richness of this data. It's so powerful to have very specific population outcomes. And we're looking at longevity, so we're looking particularly at older adults. And in England, in the south of England, there's a region called Cornwall, which has the highest population of older adults. We can focus our technology in pilots. So we're looking at patients that have sarcopenia, osteoporosis, Parkinson's disease. Without the beauty of this data set, we wouldn't know where to go. So for us, it's be able to get our product in validation with the right users over a short period of time. So this is the power of the NHS data set, so I don't think we see it anywhere else in the world.
Okay, that's really cool. So last question, I'll put this to each of you. So it is a huge healthcare. It's the biggest largest single payer in healthcare on the planet, the National Health Service. And it might seem like one system, but actually it's made up of thousands of different organizations. So it's really complex. And I was hearing speakers earlier in the week talk about Medicare and Medicaid and saying that's complex. I think we can compete with you on complexity in public systems in England. So what's been good about working in the NHS? But I also want you to share openly where your struggles and challenges have been. And what would you say to startups or companies from the United States who what would your piece of advice? Has to be quite quick because we're tight on time. So just a couple of sentences each. Ben. Good point, bad point, and why should people from the US come and work with us?
Sure. Good point is, like Tony mentioned, like the problems that the NHS is facing are really clear. So in terms of designing products, it's been quite easy to tie things and unify what all of the key stakeholders are looking for because of that. Some of the challenges, as I'm sure is everywhere, but particularly in the UK, we're very bureaucratic. So there's a lot of layers, and change management is not the easiest thing and can take time. So what I would say to people coming to the US is do your research, find the right partners, and align to where the values are.
Okay, that's good, Stephanie.
Great thing is that there's an enthusiastic base of academic clinicians who are really keen to get stuck into new technologies that are going to make them system better. And the first question they won't ask you is, how do we make this pay? Because of the financial incentives are quite aligned in our system, so it's a really good place to go early. The downside is it can take time to get a clinical study set up. The ethics process is rigorous, and also there's things like commercial governance as well to go through. So that takes a bit of time. My advice would be, again, just like you said, Ben, get the partners, find the right partners. You can reach out to these academic clinicians in these, teaching hospitals or else district general hospitals in the community, and you will find incredible people to work with.
That's good, and good. I get approached lots. Here this week, people have said to me, to me, who should I be working with in the United Kingdom? And I've already started making those connections with some of our centres. Malone, what's good, what's bad, and why should people in the US come and work with us in the NHS?
Yep. So I think what's good is the fact that there is a lot of teaching hospitals and there's a lot of universities which allow you to be able to carry out like your clinical trials, some of your research for your innovations.
So we're great at, I agree, we're great at testing and trialing. We're really good at that.
I think the bad part is more society in the UK, like race relations are not as advanced in the UK compared to the US. So starting the conversation is often very difficult for me. In terms of advice, I would say know your value proposition. I think a lot of the time in the States, the value proposition I often hear is reduce costs, increase efficiency. And in the NHS, you have to think different.
All right, Malin, that's really good. So I'd say we're great at testing and trialing, less good at adopting and scaling. You're better at that in the US. Really quickly, Ahmed, 3 quick answers.
Okay, I'll try and be quick. So what's good is the NHS Clinical Entrepreneur Program. Without it, we wouldn't be here, and it promotes leaders and innovation.
Okay, come on, what's
challenge is for us specifically the employment of exercise and wellness through social prescribing is relatively new in the NHS and in England. Hopefully it's going to get there, but we're baby steps. And advice would be find the key leaders, the key thought partners, collaborate with them early, and then you'll be guided throughout your process.
Amazing. So look, we're going to be around for the rest of the day until the conference closes. Come and find us in the break. We'd love to speak to you. We'd love to bring some of the great American stuff over to the NHS and find partners to help us test and trial some of this great stuff in the US. Thank you so much for your time.
Wait. 1 second. This is awesome. Amazing to see how this is manifested. Kudos to you and your team. What's the best ways to reach you and to invest?
Just connect with me on LinkedIn. I do that, and then we can exchange emails and take that forward.
And I think we need to start the NextMed Health Fund to invest in all of this.
Well, that's not a bad idea.
And 3, just bigger picture, there's huge workforce challenges in the NHS, US, and beyond. And I think when we did a podcast conversation, you mentioned it used to be looked upon, downward looked in terms of anybody trying to be a clinician, entrepreneur. How is this sort of program keeping folks engaged and in the workforce?
So it's been incredible. On our program, it's now 300 clinicians have returned to working in the NHS because they can be an entrepreneur as well. And we are going to make an announcement later this summer. I think it's already out in the public domain, where we've now persuaded our healthcare system that backing things like this, innovation and entrepreneurship in healthcare. So from later this year, we have 30,000 trainee doctors. We're starting with them, funded by the National Health Service. Everyone will be able to take 1 day a week of their time that will count towards their training to do research, education, quality improvement, but innovation and entrepreneurship too. And I don't think that's, you imagine 30,000 doctors having a day a week to do that. Wow. And that's come about because you invited me here 10 years ago. It would never have happened without it.
Magic. So we have challenges with nursing students, pharmacy students, and others, and this program is an inspiration. You don't need a whole NHS system to do this sort of thing. What lesson could you put NHS entrepreneurship program in a box to help other systems, small and large, do the similar program?
So absolutely. The Australian government have worked in partnership with us, and in 3 states in Australia, the program is now being rolled out there. And there's no charge for this. We don't make any money on it. What we want is we want to work in partnership. How can we build great life science companies together? How can we develop trading relationships? So now the Republic of Ireland, Northern Ireland, Scotland, Australia, we're in conversations with Sweden and Finland and other governments and the Ugandan government as well to look at how we might actually build collaboration in healthcare through startups and through entrepreneurship. There are businesses in every single country in the world. Could this be that route through to getting the latest, greatest things into healthcare across the planet? I think it could.
Right, so the challenge for everybody here and online and beyond is to learn from this program and build versions of your own. So thanks, everybody.
Great, thank you very much.
All right. right, so while we reset the stage, I'll set up this next session, which I think is at the root of a lot of our sick care system in general. That is sort of metabolic disease. I was lucky to keynote a few months ago a session for Diabetes Mind in San Francisco, led by an amazing set of often engaged patients, the We Are Not Waiting crowd, who have been very involved, particularly in type 1 diabetes and now type 2, in not waiting for solutions but building them. And I met Dr. Robert Gabe, who's the Chief Scientific and Medical Officer for the American Diabetes Association, who's going to help lead a session looking at the future of diabetes, metabolic disease, with several NextMed Health faculty. So over to Robert.
Wow. What a few days this has been, and so excited to be here and talk about something that you may wonder why. We've talked about really sort of big picture things, but not specific diseases very much, just a little bit of that. And you might wonder, why is there a session devoted specifically around diabetes and obesity? And I would argue that diabetes has really been at the forefront of a lot of innovation in healthcare, a lot of the key principles that have developed over time. Whether that is the idea of the importance of self-management or team-based care, concepts that came to the diabetes world almost 100 years ago with Elliot Jocelyn, and now have permeated across the ecosystem. You can think of other things like population management and disease management. Often those started with diabetes. And now as we're moving into technology, assisted care, digital health, a lot of the work is being done around diabetes. And you might say, well, why? And I would say it's the 5 C's. So first of all, diabetes is common. 37 million people, 1 out of 10 adults. It is costly. 1 out of 4 healthcare dollars in the U.S. are spent on diabetes and its complications. It's complex. You need multiple different specialists and behavioral aspects all to work in concert to be able to effectively manage diabetes. And it's calculable. You can measure it in many different ways. There are clear goals, there are numbers, it's data-driven, glucose values, all of that makes it really particularly wonderful for the digital health and the ability to be able to manage all of that complex data. And then there are the comorbidities. So a program, an effort in healthcare can start around diabetes and then quickly move to hypertension, hyperlipidemia, cardiovascular disease, kidney health. All of those stem from diabetes. And so you've really seen this at the forefront of many innovations. And we're going to hear an example of 4 wonderful innovators in a moment. But let me frame what the challenge is when we think about the situation. Is, in the last 10 or 15 years, we've just had this incredible explosion of new therapies and technology. There used to be only 3 classes of medications. Now there are as many as 15 different classes to manage diabetes effectively. And technology, continuous glucose monitors, automated insulin delivery, and we'll hear about those in a moment. And yet, what do you think has happened with glucose control, the biggest predictor of all of those complications of diabetes? With all of this new innovation, what do you think has happened? It's really not changed at all. So we've made no progress despite all of this. And so the question is, why? Why, with all of this new technology, have we not moved the needle? And really, fundamentally, it's around adoption. all of these therapies are available, but they've not been implemented. There are all sorts of wonderful tools that have not been adopted. And I think that's a theme throughout this conference. We've heard of all of these wonderful technologies and approaches, and yet we're struggling with adoption. So in the diabetes world, if we try to think about what are the different aspects that need to be addressed, I would say there are 4 key domains. First of all, on the clinician side, there we go. Okay, excellent. So on the clinician side, there is this matter of trust, and I think that's particularly problematic in digital health, because it's sort of the Wild West from the clinician's point of view. There's so many solutions. How do I know what to recommend? This is where being able to vet those in some way. At the American Diabetes Association, we're working with the National Center for Quality Assurance to establish a certification program that digital therapeutics can go through, and then clinicians will have trust. We also publish the most widely recognized guidelines, and that's the other thing that helps clinicians to adopt. But beyond all of that, that is sort of the gating piece of this, but that's not sufficient. It really gets down to time. And if you follow any clinician around, they're just frantically moving around. And if you can't show that you're saving time, forget about being time neutral. If you can show that you're saving them time, that's much more likely to get adopted. And so that's sort of the clinician side of things. From the person living with diabetes, really first and foremost, if you ask them, it's about burden. I want to reduce the burden of having diabetes. And we'll hear a great example in a few moments of work that's being done to address that. So there's that piece. And then the other inspiring story that we'll hear in a moment is this DIY movement, this effort to take care into their own hands and come in for their own solutions. And that has really pushed the industry and pushed everyone to move faster. And I think you'll see much more of that. So what about from the payer side? The challenge in the world of diabetes is, of course, it's all going to be on their decisions are going to be based on ROI. But the challenge is the time horizon. So many of the complications of diabetes take years to develop. When you think about obesity, even more so, those complications take time. So that time horizon becomes critically important. And you can get around that if you have to be able to look at a 1-year time horizon, which often is what one is forced to do. And then you just have to take the really high-risk individuals. And the higher the risk, well, the shorter the time horizon, and you can show benefit. But for a lot of the therapies and amazing predictive value tools that we've heard about over the last few days, you can diagnose people earlier, but you're not going to save the money for a longer period of time. And that's a challenge of the U.S. Payer system, less so in other countries, but still they do have some of those same challenges. And so being able to think through that is going to be an important piece of adoption. And then the last piece of adoption is from the regulatory side, and this is where the story in diabetes has really been inspiring, because people living with diabetes have been able to be strong advocates, and they've really moved the FDA in approving things that frankly are surprising. So the new therapy for the delay of the development of type 1 diabetes got approved on a pivotal trial with only 100 patients. Imagine that. I mean, that is really unusual. So laid the groundwork for this, and now I'd like to bring up this incredible panel, and you're going to hear some incredible examples of innovation to attack these problems. So let me bring up the panel. Come on out. And so we're all going to assemble here. Everyone's going to speak, and then we're going to have some time for a discussion. So first, I'm really pleased to have Kelly Watson come up that has an inspiring story of tide pool. So Kelly.
Thank you, Dr. Bob, for that
introduction. And let me give you your clicker, yes.
Thank you. All right. Good morning, everyone. Whoop. Tidepool is a nonprofit organization. We were founded in 2013 with a mission to make diabetes data more accessible, actionable, and meaningful. To date, our existing tools have supported over 400,000 people with diabetes and their clinicians. Today, I'm excited to share more about the history of Tidepool Loop, our recent FDA clearance, the We Are Not Waiting community, and the power of patient-led innovation. Let me start by asking you to imagine something. Think about the next 4 to 6 hours. Imagine having to keep track of everything you eat, every macronutrient in the exact quantity, and quantify your recent activity, your activity to come, your sleep, and your stress. And now if you're a person who menstruates, consider where you are in your cycle. Now imagine there are over 40 other factors that impact how to calculate a life-saving medication, and you will need to do this 5 times a day, knowing that if you get the math wrong, it could be a matter of life or death for someone you care about. This is the reality of living with insulin-requiring diabetes. Globally, people with type 1 will lose 32 healthy years of life, and 1 in 3 people will die before the age of 55. In the United States, people with type 1 will lose 22 healthy years of life. 3 years lost to treatment and care, 6 to complications, and 13 to shortened life expectancy. And taking off my Tidepool hat for a moment, as our founder Howard likes to say, I know this reality firsthand because my partner Daniel lives with type 1. And 7 years ago, we both reached a breaking point, exhausted by managing this condition. Like many others in the We Are Not Waiting community, driven by the need to better support our partners, our children, or ourselves, we rejected the current state of diabetes technology. Along with thousands of others to come, we used open source code to build an automated insulin dosing system called Do-It-Yourself Loop, in an effort to reduce our burden and get some of that lost time back. If all people living with type 1 could access tools like continuous glucose monitors and automated insulin dosing systems, 7.3 of those 22 years lost would be restored. This is why I'm here today. In late 2018, Tidepool announced our intention to take a version of the Loop system through our quality system and work with commercial device manufacturers and the FDA. And we are proud to share that on January 23rd of this year, we received FDA clearance of Tidepool Loop. Thank you. And as much as Tidepool Loop's clearance is a breakthrough for the diabetes community, as Stacy Chang shared during the opening sessions on day 1, the secondary effects are important to focus on here. Tidepool Loop's clearance and our unique path to bring forward patient-led innovation, support patient preference, interoperability, and use real-world evidence has the potential to unlock further innovation in diabetes and beyond. Unlike industry, the open-source version of Do-It-Yourself Loop was not initially designed or constrained by the factors that Dr. Bob shared, the regulatory roadmaps or business needs. Rather, it was designed to meet the needs of people with diabetes and their caregivers frustrated at the current state of their tools. The absence of feature selection bias meant that the product truly reflects the needs of the users around support for discretion, Tidepool Loop is the first cleared product on an iPhone and an Apple Watch. Support for greater configurability. Tidepool Loop is the first product cleared to support customizable target ranges. And thanks to progressive thinking from regulators, Tidepool has pushed these features that support patient preference forward, including the need to support patient choice in the diabetes devices used. And while there's still work to be done, this represents a step towards a future where plug-and-play interoperability is supported in diabetes devices and beyond. At Tidepool, we like to say we're standing on the shoulders of giants, including the We Are Not Waiting developers and organizations like JDRF, Helmsley, ADA, and industry partners. And importantly, because of the 1,000 participants in real-world observational study of do-it-yourself loop, Tidepool has successfully forged a new path using real-world evidence as a primary means for demonstrating safety. Lead users exist in every industry, and so I charge us to find the people with both the deepest understanding of the needs and the solution, learn from what they are building. As we've been reminded many times this week, innovations in technology alone are just the first step. We must not forget that people living with chronic conditions like diabetes approach technology as people. We come with fear, and we come with hope, and we come for community. And so I ask us to reflect on this question. What if patients taking command of their data could change healthcare? Tidepool Loop's clearance demonstrates what working hand in hand with lead users in a community can do to drive profound change in the system's fundamentals. There's work to be done to advance new models of care that take into account our overburdened providers and our healthcare system's needs and align incentives. Let's continue to bridge this gap together as a community. Thank you.
Excellent, excellent. Such an inspiring story of people taking control of their disease and making a difference. Now we're going to move upstream somewhat, and Dr. Lydia Alexander is going to talk about the, I think in many ways, having been in this field for a long time, obesity is having a moment. And we're going to hear about from the incoming president of the American Obesity Society, Lydia Alexander.
Thank you. So what if I told you that we could have drastically reduced the incidence of 13 different types of cancer, heart disease, reverse the majority of type 2 diabetes, and even improve people's mental health just by treating one root cause disease? Would that seem too good to be true? Well, it can happen, and it's happening now. How? By treating obesity. 75% of our country is having a weight problem, and it's impacting their health, and it's impacting our health care system, which is really a sick care system. Systemic inflammation as part of excess weight begins much, much sooner than the 30 to 60 pounds a person needs to gain to develop obesity. Obesity fueled the COVID-19 pandemic. Death rates are 10 times higher in countries where more than 50% of the population has a weight issue. This is because of systemic inflammation. 100 million US adults are trying very, very hard and spending over $300 billion trying to lose weight, unsuccessfully. And this leads to a cycle of failure, frustration, self-blame, and guilt. And it just doesn't make sense. How can 75% of the country be trying so hard and failing so badly at losing weight? What if obesity isn't just a lifestyle problem? So my journey began when I was a medical resident. I was caring for people in the hospital day in and day out, a lot of them with complications from type 2 diabetes and cardiovascular disease, some of them in their 40s and 50s. And I kept wondering, how did they get here? How could we have prevented this? And I wasn't getting any answers because, again, it's sick care. We're just turning people around, teeing them out, sending them out, and hoping for the best. So fast forward my completion of residency and the opportunity my outpatient mentor gave me to join Kaiser's medical weight management program. So I didn't really know anything about that or about treating weight because we didn't learn about it in residency or medical school. But it was a part-time opportunity, and I had had 2 kids in med school and 2 in residency, and that seemed like a pretty good idea. And so I started treating these patients, and they would lose 40 pounds, 60 pounds, 100 pounds. And like magic, their chronic conditions improved. They came off their meds. They got their lives back. Health, freedom, more time. And I thought, wow, this is like the labor and delivery of adult medicine. I'm in the right spot. But then, a lot of them started regaining their weight. And all these conditions came back. And it felt, again, like we were rearranging the chairs on the Titanic, just like when I was in inpatient medicine. And so I got a research grant from Kaiser to evaluate the program and see were we really making a difference. And it turned out that our study showed that 4 to 5 years out, we were achieving sustainable weight loss of 4 to 5%. That 10 to 15% that we needed that was reversing all these conditions only lasted for about a year. So I decided to learn a little bit more about this, and I got boarded in obesity medicine, lifestyle medicine, and I even trained as a culinary chef, a culinary medical chef. And my conclusion was that obesity is a chronic, relapsing, treatable neuroendocrine disease. It causes or worsens dozens of medical conditions. Appetite and weight regulation are strictly controlled by the brain. That's the science. That's what the data shows. There's central systems and mechanisms at work, and also peripherally in the pancreas, in the gut, in the adipose tissue. So that got me thinking. I wish we lived in a world where I could get more data and show that if we treated obesity, that we could have the outcomes. We could reverse type 2 diabetes and all those other conditions so that people would listen, and then we could make this happen. And then I had a realization, this data exists. Bariatric surgery. Bariatric surgery improves health. It improves cardiovascular disease by 40 to 60%, 8 years out. And that's major adverse cardiovascular events, death, and everything in between. And speaking of that, weight loss post-bariatric surgery cuts death rate in half for those 13 different cancers that I mentioned. Bariatric surgery reverses type 2 diabetes, or at least puts it in remission, for 75% of people, even 5 years out. It lengthens life by 6.1 years. Bariatric surgery is actually a metabolic surgery. When you tinker with the gut and you change it around, you also affect all the hormones that signal the brain about appetite and weight regulation. We need about 10, 15% weight loss to reverse a lot of the conditions that I just mentioned, and also sleep apnea, fatty liver, blood pressure, and improve physical function. So what if we could get surgical results without the surgery? It turns out that these days, it seems like we can. The obesity drug market is set to double in the next 4 years. The market today is vastly expanding. 2023 to 2026, a bunch of phase 2 to 3 trials, and so much more in development around hormones and all those different transmitters that I mentioned work in the brain and in the rest of the body. And so more diverse and targeted medications are going to give us the opportunity for precision delivery and applications. Semaglutide, which is the new darling of this space, also known as Wegovy, works in 92% of patients. And 1/3 of them are able to achieve surgical level weight loss. Tirzepatide, also known as Mounjaro, not yet FDA approved for weight loss, but approved last summer for the treatment of type 2 diabetes, does the same thing, but instead of one hormone, now we've got 2 hormones in this medication, so it's even a little better. We also have the outcome studies, just like in bariatric surgery, that show that these GLP-1s, that's the name of this class of medication, improves MACE, major adverse cardiovascular events, type 2 diabetes, and has mortality benefits, just like bariatric surgery. But we also know that single interventions cannot achieve weight loss. We know this because of all the other chronic conditions that we treat. Medications are part of the puzzle, but alone, they're not enough. There are issues with medication compliance, and we also know that you need lifestyle intervention to actually improve the biomarkers, body composition, and much more to create that health and that longevity. So we need the right tech-empowered ecosystem to create healthcare that is continuous, virtual, personalized, tech-empowered, and value-based. And that's Inara. Inara is a digital health clinic focused on tackling obesity. We're turning a fragmented ecosystem into a one-stop personal experience for a patient using their home medical clinic as a touch point. We've identified 9 key factors that are central to treating obesity. 4 of them are listed here: the nutrition, physical activity, behavior, and medical management. And so the Inara difference is that we have a responsive design, and it optimizes the timed interventions and which interventions we should choose and when. And then these different comorbidities improve. So the program is virtual. It involves synchronous care, asynchronous care, and a data-driven approach, producing better than clinical study results insurance covered. A paper we published in 2019 showed sustained weight loss of 14.2% at 18 months. And what's interesting to note, that was back in 2019, 45% of those patients were not even on anti-obesity medications. Fast forward to Inara 2022, and the 36 weeks outcome studies that we have show 17% sustained weight loss compared to the same time point of 36 weeks for the Wegovy Step 1 trials of 13.6%. An IRB-approved study that's going to be coming out that we're working on in the next couple months is going to show sustained weight loss at 36 months, and also at 48 months once we get more data there. And that's starting to eclipse sleeve gastrectomy results. Obesity medicine is going to be at the center of a diagnostic, pharmacologic, and behavioral shift in how we understand, segment, and treat chronic disease, because it's the majority of the country. A revolution in medical care is coming with obesity medicine and AI-empowered tech at the epicenter. And we're inviting the world to join us in treating the roots, not the fruits of obesity, with obesity care everywhere. And that's life-changing weight loss. Thank you.
Really exciting data and great outcomes. And now we're going to move to the person that has traveled here, I think, the furthest.
Might be, yeah.
Yes, the winner of that award, and Ali Hashemi, who is leading in a really interesting care model called GluCare Health. So, Ali, please.
Thanks. Good morning, everyone. By now, you've digested your breakfast and you're starting to come off that peak of that glucose spike. So if anyone falls asleep, I won't hold it against you. I noticed that it said Dubai after my name. I think I'm the only one whose geographic location was referenced in the intro. So my name is Ali Hashemi. I'm the co-founder and CEO of Metabolic. Metabolic is a platform that we've built. We built it in Dubai. It does a couple of things. I'm only going to talk about one of those things. One is it drives a clinical platform called GluCare.health. It is a medical practice, regulated, doctors, nurses, the whole kit and caboodle, focused on the treatment of diabetes and prediabetes. It is a hybrid model, both virtual and physical. There's a whole bunch of tech behind it, and I'll get into that. On the other side, and I'm not going to talk about as much, we run a platform called Zone.health, which is a medicated weight loss program talking about all the great innovations in pharmacologics. It's direct-to-consumer for non-diabetic weight loss. Okay. So the great benefit of being last, not just among this illustrious group, but also last day, is that I've had the privilege of listening to a lot of people much smarter than me say really great things, and my speech has largely been written for me. Lots of lessons learned. Lesson number one, that there's nothing an audience loves more than a good before and after photo. That came from from David a few days ago. So here you go. I can't take this back. It's out there. Okay, now you've seen it. Ali, a couple years ago, you've seen it along with 65,000 other people, by far and away my most popular LinkedIn post ever. But this described my own journey. A couple of years ago, I was not in great shape. I'd been in great shape younger. While I was in medical school, I was actually spent more time in the gym than I did in my books, I think. But, life got in the way. Profession got in the way. I had kids that it's a joy, but sometimes they get in the way. And, that slippery slope. And I got to a point where I was 90 kilos, 195 pounds-ish. I had fatty liver. I had high cholesterol. I had high uric acid. And I've got a lab in my basement, so I test myself all the time. I became pre-diabetic in the middle of opening a diabetes center, which is obviously not a good look. So I became a patient at my own clinic and turned that guy into that guy in about 4 months and reversed everything. How'd that happen? I'll tell you a little bit about the journey, and then we'll dive into sort of the nitty-gritty of it. The clinical experience is unified and continuous, and we built it from scratch. I walked in as a patient, I registered, I got my bloods drawn immediately. We have a lab on premises. The bloods go down to the basement, I go up to the coffee shop and I break my fast. By the time I've done that, my labs are done within 30 to 40 minutes, and the results are already on the physician's screen. So I go in to see my endocrinologist. He's already got everything that he needs to talk about teed up, and we have a long and detailed conversation about all of my biomarkers and how they interact. After seeing the endo, I go and see the rest of the care team. Diabetes educator, nutritionist, dietitian, and a health coach. That health coach is key. She connects me with all of the devices that I need, all the apps that I need to download, and helps me navigate what happens the next morning when I wake up and I'm no longer at the clinic. But I'm still connected to the clinic, and I'm still connected to the entire care team, and they're connected to me. So my journey over 4 months, it did include Ozempic, but it also included one of these, and it was this magical, curated journey of discovery through my own data, and a hyper-personalized experience of learning about what caused what and what lessons I needed to learn and how I could carry that forward. So I lost 40 pounds, reversed everything, and I've kept it off so far for the last 2 years. Okay, so what is GluCare? I'll skip all the sort of text, but we are a hybrid physical and virtual model, and we have a single North Star, which is to use all the great tech that every one of these conferences talk about in a synthesized and unified way to drive one thing, an outcome. And the derivative of that outcome is human behavior. So really what we are is a behavioral change engine, which is this sort of curated journey of self-discovery through your own data. But let's rewind, sort of big picture. Why are we more metabolically dysfunctional than we've ever been in human history? There's some fundamental truths. It's a 24/7 condition. Any of you in the audience with chronic disease, you know that. As a diabetic, it's even worse. You're going to spend hours and hours self-managing. Your access points to the healthcare system, your insurance company, you name it. Getting lab tests, seeing your endo, seeing your podiatrist, seeing your cardiologist. It's never ending, and it's terrible. But the healthcare system treats it as if it's just an episodic thing. Now, it's not a problem of lack of innovation. We've been innovating for the last century on every dimension related to healthcare. Every single dimension has gotten better, not worse, from our pharmacologics to our devices to everything in between. So what is it a problem of? It's not a problem of genetic predisposition, because our genes haven't meaningfully changed in the last 50 years, have they? Our phenotypic expression has, but then that gets back up to the point of behavior. And we also, as many people in the last 4 days have mentioned, we also have an incentive problem. Well, the healthcare system, Ken, John, and Michael all echoed the same points. The healthcare system is working exactly as it's designed to, but the incentives are wrong. We also have an execution and integration problem, and that's where crazy entrepreneurs like myself come in to try to synthesize all this stuff and put it to practice. But Parisa put it really well. She said that innovation is outpacing implementation in clinical practice. And that is actually an interesting problem, because we'll be having the same conversations next year and the year after in conferences similar to this. Alfred talked about the next step. Even once you implement, how do you personalize that at scale and make it impact a lot of people? And Rasu's quote I loved, which is, if you apply digital to a broken process, all you're really going to end up with is a broken digital process at the end of it. But fundamentally, we have a human problem. Imagine the last time any of you went to see your GP. Actually, you're all doctors, so you probably don't do that because you're notorious about not caring for yourself. Imagine you had seen a GP. That visit would have been 10 minutes. The GP would have spent 90 seconds looking at you, eye contact, and probably 9 minutes tapping away with 2 fingers, struggling with the EMR, putting a bunch of nonsense information in there and not forming a human connection, not actually planting the seeds of trust and engagement that you need to engage, build trust, and to change. It's a human problem. Think about everything else that's happening in the room. The architectural design, the furniture selection, the wardrobe selection. There's a giant desk separating you from your physician. Your chair is at a lower level than the physician, so the physician is literally looking down on you. Right? Some people are smiling. Yeah. It's true. I mean, we perpetuate this legacy in the system that none of us ever really think about. And none of this is tech. It's not rocket science. It's common sense. We just sort of took the time to think about some of these things. Ron, after a brilliant talk, ended with this thought, that it's all about the human touch. And then Nicole took it a step further, and she said, well, even if we have the human touch, maybe we actually need to get better at being human. And then Paul, well, maybe that's not as relevant. So we actually have no agency over our health. This is an agency problem, right? If I ask any of you, how did your breakfast affect your metabolic health today? You wouldn't know. And if I said, what about all your last 365 breakfasts? How has that impacted your overall metabolic health for the future? You'd have no idea. This is an agency problem. You don't have the data to affect the change that you need to affect. But how do you solve this, and more importantly, how do you earn the right to win? Earning the right to win in this context is achieving the best possible outcome at the lowest possible unit cost. And what we've tried to do is look at it as a baby would, fresh eyes, no biases, with gleeful irreverence to what the rules are, the way the system works. And candidly, we didn't really care about making money. We just wanted to build something that worked. So we built GlueCare from scratch. We built our own center, 10,000 square foot facility. Again, a regulated entity. It's a clinic, it's a facility. It has staff, it has insurance contracts. It functions as a traditional clinic would. But it's powered by this amazing tech platform that allows our patients to experience their data on a continuous basis. We built a whole front end, back end, and everything in between to allow our patients to interact with their data. We broke down all the silos of all the data sources, all these devices. I have a team of 20 engineers that are constantly breaking things and hacking things and putting them together, and we create a really nice unified data experience for our patients. We built a beautiful facility that doesn't look like a medical facility, and candidly, it's a lab. It's a sandbox for us to test, fail, iterate, improve. We're constantly improving. But it was important to build it. And hopefully that's the first and last one that I have to build, because I don't want to be in the clinic building business. But we built it so that we could control it, and that we can control everything that happens within its four walls from an incentive perspective. We're punching a little bit above our weight class in terms of some of the partnerships that we've had. So we're the first facility of any kind in the world, and this is something we're really proud of, to be accredited by ICHOM, which is the International Consortium of Health Outcome Measures, as a value-based care organization, which is kind of cool. We did a partnership with Novo Nordisk last year. We're the first example of its kind of a fully at-risk medicated weight loss program. If our patients don't lose the weight, they get a full refund. Convincing a drug company to give money back to a patient is kind of like taking candy away from your kids after Halloween, but we managed to get that done. And the team at Novo were great. But what an amazing program. It's not rocket science, not really that innovative, to be candid. You know, satisfaction or your money back is a thing that people do in other industries. We don't really use it that much in healthcare. So what's the punchline? And this will kind of wrap us up. It works, and it works really well. Candidly, a lot better than I thought it would work. So this is our 3-month data. We're achieving over 2% reduction in A1C. In parentheses, I put 2.4 because that's our engaged population. Your population is always a mix of people who opt out and opt in. So we're achieving incredible reductions in A1C. I'm not a fan of using A1C as a measure. I prefer time and range, but then everyone's got to be wearing a CGM, which is not financially sustainable. So we do talk about A1C. But across the board, we've reduced every single meaningful biomarker related to metabolic disease. And we've done this in 3 months. Is it meaningful? Let's look at it in terms of comparison on others. Now, these are our peers. I call them the OGs, the version ones, the early innovators in the digital health space. Most of these companies don't have the fully vertically integrated platforms. They're digital. They sit on top of the healthcare system as a layer, and they don't really have the ability to push and pull on the levers of cost, of incentive, of behavior. And so in the genesis of GlueCare, we thought about that, and we thought, well, if we do pull on those levers, if I do control the physicians and the pharmacists and the lab, and I'm able to control these incentives, my results should be better, and they are. So our 6-month results are about twice as good as the best published results that I've seen for Livongo in about half the time. But more importantly, it's more than double the results of our best peer group in the UAE in about 1/40th of the time. So it's working. I'll conclude with this. We spent a lot of time talking about innovation, and I love these conversations. But ultimately, sometimes we lose the forest for the trees. And we're talking about the tools themselves, but not talking about how to make those tools useful and how to drive to an actual impact or an outcome. And that is a very human story. Thank you.
Great, thank you, Ali, and really an amazing setup that you've created. We have a few minutes for a discussion, so maybe I'll just start with you, Ali. You've created this new ecosystem, in essence, from scratch, which has given you the ability to sort of design it right, so to speak. What are your thoughts on scaling?
Yeah, so our scaling model is different from our historical model. The historical model, building everything, was a 4-year journey, and we were just quietly building, not talking about it much, letting the data speak for itself. As we go forward, like I said, I don't want to have to build a single clinic. I'm working with partners now to do that at scale. So for example, and this is off the record, I know this is on the internet, so it's not off the record anymore. We're working with a regional government now to deploy 100 centers simultaneously, well, over the next 5 years. So almost blanket the country with a fresh, de novo metabolic platform to care for all of its citizens. And the mission for just that project is to manage 1 million patients in 5 years. Imagine the amount of life years we're going to be able to add, just in terms of healthy life extension that my colleagues have talked about earlier.
Wow, amazing, amazing. Lydia, I start off by saying, obesity is really having this moment in time, and there's just incredible press coverage, and people have raised the awareness, and still there's some barriers to thinking about it as a disease and treating it in the way that you've developed. How do we get past that? First, do you think that's true, and then how do we get past that?
I think that's absolutely true. I think we still treat obesity as a personal failing, and I would say that obesity is having its moment right now because we have hormones that we know if we give them back and replace those that are deficient or resistant, that weight improves, and it's improving on a scale of magnitude far different than it ever did before. 4 to 5% weight loss in the diabetes prevention program, studies was very exciting that people could achieve that for 5 years. And now, 15, 20, 25%, and it's bariatric surgery level. So I think that's going to get people's attention because we have medications to treat a disease just the way we have medications to treat other diseases: blood pressure, cholesterol, thyroid, depression, and they work, and they work in a medical setting.
And so maybe to follow up on that, and we were talking backstage a little bit, the question that always comes up is, so do I have to continue to take these medicines?
Yep, and that's the $1 million, $1 billion question. And the answer is, do you ask that question when somebody tells you you have a thyroid issue and you have to go on thyroid hormone? Or a blood pressure, cholesterol issue, and you need a cholesterol medication, or depression? And most people don't ask that question, maybe with the exception of some of my patients with depression. And the answer is, for some people, yeah, that is going to be it, because weight set point and metabolic adaptation are real things, and the body is having a computer malfunction, as it were, and thinking that we belong at a weight that's much higher than we need to be at energetically, and so we need this hormone to improve that. And for some people, just like depression, maybe you need to stay on that medication forever. And for others, maybe you wean it off and they do well. And the answer is we don't know. It really depends on the individual.
And maybe that's where, you know, we haven't fully accepted obesity as a disease because we don't think of it in the same paradigm, and there's the blame and shame and all of those things that need to be addressed. You know, Lydia, from you know, one of the inspiring parts of your story and the incredible DIY movement in Tide Pool has been to sort of mobilize the community to help themselves, and a lot of that is around reducing burden, and you gave the example of your partner and the burden there. Where do you think the next opportunity to reduce burden can be for people living with diabetes?
Oh gosh, I think there are so many ways to answer that question. You know, primarily right now, I think we need to address the healthcare provider burden. The burden of getting access to data in the first place from all of the diabetes devices that support patients. That seems straightforward, but it's not simple. Getting access to the data first and foremost is important. And for patients, you know, we're seeing a lot with AID technology, the ability to streamline how the systems are initiated. The settings that have to be input by providers, helping that transition to primary care, being able to establish and get patients up and running, being able to support less manual input, as I mentioned earlier, from that person living with diabetes, not having to track so much from their meals to their activity, having that as automatic in the system. So I think, you know, there's a lot of focus here on both the provider side as well as the patient side at reducing burden and getting people access to this technology and getting people access to the data from the technology.
Yeah, I mean, everybody across are all burning out. It's a lot. We're running out of time, unfortunately. So I like the technique that somebody used earlier, that if you had to have a Twitter quote from your talk, think of something that you could post. Maybe I'll start with you, Ali. What would be your Twitter feed?
Put me on the spot. Okay.
I know it's a tough one. I'm sorry. And you can skip it, and someone else can go first if they're ready.
No, it's fine. I think I'd go back to the last slide, which is that the future of digital medicine isn't digital, and it's not about the tools. It's about the human.
Excellent. And Lydia?
Treat obesity first. It will revolutionize healthcare.
Awesome.
And find the lead users. Find those patients that understand the problem and that understand the solution that needs to be built, and talk to them.
And I guess I would say, really, having been in this field for so many years, there couldn't be a more exciting time and more tools and promise to help people live healthier.
Absolutely.
Great. Well, thank you all for a great conversation, and thank you.
Thank you. Shafi, you can't go anywhere.
Yeah, I can't go anywhere.
You're well dressed.
I was going to say, where's the tuxedo this morning? Surgeons in tuxedos.
So.
Thank you. Let's start out with that. Thank you so much to those who have joined us online, and they have been incredibly active. If you've liked what you've seen, next time come and join us here. The other part we need to thank are those of you who are here with us. It takes a lot of trust, a lot of time, a lot of resources to make sure that you get here, and it has meant not only the world to us and to the team, but I think to each other. That's kind of some of the reaction that we're getting.
Yeah, I was wandering around last night, and like all these amazing people I just manifested here.
I know.
Like, how did you show up?
How did you show up?
I had no idea you were coming, or who you were, or how you managed to find us.
Yeah,
So really appreciative that you guys all took the leap of faith, especially with our new iteration, to join us this year.
Yeah, your support, we felt it. We felt very cherished, and we felt like that we will succeed.
And we want to, as we'll talk about in a minute, ask you to keep helping us as we grow this community and a platform. Also, huge thanks to our amazing faculty. Let's give up our faculty, like 74 faculty around the world.
Yeah.
all volunteers, all put their heart and soul into this. Many traveled from as far away as Dubai, Israel, UK, to be here. So we know it's a challenging window to travel still, and appreciate our amazing faculty and our vanguard. We have a whole group of folks who've helped out in spreading the word and helping us build thought leadership. So huge thank you there.
Yeah.
Also, big thanks to our partners, for which this would totally not have been possible.
Yeah. And when we say partners, those are names of companies, but they're very important people who have been champions. So I really want to make sure that I give a shout out to Peter Flashner with Click, and to Kelly McPherson, who run a whole lot of magic. Maria Filipova, who is just a force of nature with CareQuest Innovation Partners. Caroline, again, Rajiv, Kristen Lawson, Bobby, thank you so much for thinking about us. Deloitte, Asif, again, these are company names, but there are people behind all this. Pronuvo's been...
Raj and Raja for joining us. You all will have an opportunity, those who came here live, to get a Pronuvo scan with a significant NextMed Health discount, so watch for an email about that. I just did it.
Amr, one of my favorite engineers with Rainbird and Rolanto.
Yeah, Rainbird and Rolanto, they were fantastic. Thank you to both your teams. Fountain Life, who couldn't be here in person, but Bill Kapp has been...
But believed enough to say, we want to support you.
He came to prior programs that really helped shape this Fountain Life platform. It's really integrating a lot of the tools and technologies we've heard about to extend healthy health span.
And Dave with LiveCore and Seema with Cure. So again, you see those company names, but there are people behind that. And then the other group that we really want to say...
Before that, I would say anybody else interested in partnering with NextMed now, near, and next, not just for next year's program, but in the interstitials, please find us.
All the things. The other thing before... I think very much about, in our healthcare systems, our workforce. And one of the things that I tell leaders, when you take care of the people who take care of the people, that's when everything goes right. And there, behind these curtains, that is where magic happens. So I'm thinking about Russell and Simone and Heidi and Dave. We've got a lot of Daves. We've got people back here, for those of you who've been seeing all of the hive of activity that make sure that we feel confident that we're up here on stage. Illyri and Emily, these are all folks who actually chose to be here. Our production team is actually from around the world, and when they heard that we were bringing this back to life, they said, count me in. And like I said, when you take care of the people who take care of the people, that's where real magic happens. So to Jason and the E2K team, when you see them wandering around making sure that all of this works, please give them a high five, ask them if they want a hug, tell them what your experience has been, because we cannot do any of this without them. So I wanted to say thanks to them from my heart.
Absolutely huge thanks. Production team's amazing. And they definitely rolled with all our amazing improv.
Oh my gosh, and we roll nimble.
So especially Jason Greenberg, he lead Ropina TV.
Everything is
David
possible.
Fratto, all the amazing work from the graphic side from
Beautiful
before.
photos. Janetta is doing all
during and after. Sarah for organizing all the amazing volunteers you saw in Scrubs. Many of them were medical students, nursing students, and others.
Yeah, and there are two people that aren't here, but are so important in the background. So Erica, thank you for all of the beautiful iterations. And I'm so proud and grateful for the design that we have. How many love this NextMed logo? That is the work of Bonnie Siegler with 8.5 Studios, who really, when we gave her the brief that said, we're not like other healthcare conferences, we do things differently, we want to unsilo, we want to invite people in, we want to stand out, and she delivered. So I wanted to make sure that we named them, because when you hear your name, you're known and you're loved.
So again, huge thanks. Let's get up to the entire production and everybody else. So
everybody, I think we would like you to stand up and stretch.
Stand up, stretch, but don't go anywhere. Also, big thanks to my parents for making me, my wife Tracy, and kids for letting me be here.
But that microphone is in the middle, so I want to hear what your thank yous are, what your insights.
Insights and comments. We want to help iterate and not have a failure of imagination about what's possible.
It's a conversation. We've been doing a lot of the talking, so we'd love to hear. We're here listening. Oh, there's a friend, family member, John Madison. Thank you.
May I say something?
Please.
So,
be brief.
Not only is this the best health tech conference and assembly of people in the world, the way that the two of you, Shauna and Daniel, curate this group is a blend of both pioneering innovation and heartfelt commitment to change the world.
Progress.
I have made more good friends, lifelong friends, in the past decade at this conference than any other activity in my life, and I thank you both so much for that. And those of you watching live stream, you need to come. You will find your kin here who are dedicated to changing the world for the better. Thanks to both of you.
Thanks, John.
Dancing Queen.
Hi.
Hi, you got the moves, girl.
This is so high. Hi, everyone. I'm Marwa. I'm here from Canada. And I just want to say it really is quite a different health tech conference. Like in other conferences, I feel you walk up and if you're not like a buyer or something, people don't really want to talk to you as much as here. Here, just everything is a possibility. Everybody wants to pick your brain about something, and it's just like the currency is knowledge, which is really, really cool. The other comment I'm going to say, Persa here, we need more pharmacists. So
yes!
anyone out there, come. It's great. It's amazing. It's not just a doctor-led conference. It really is a clinician, but we do need more pharmacists and nurses. Yes.
Got it. And I see some of our Dutch folks leaving, and I want to have a special shout out to Lucienne England.
Ooh.
Oh my God. So much love for our Dutch community.
We almost went with orange. We had more gold, but for the entire theme. So.
Yeah, no. But we do. We appreciate the fact that you come in mass, you bring the energy, you bring fun, and you are really pushing the envelope of pushing us to lead better. So, any other? Stretching? Do we have?
This is a stretch comment thing. Yeah. So one thing we want to ask for here is how do we continue the energy here? One of our amazing participants, Philip Edgecombe, who's
family, I guess.
Yeah, been several times. He's now a medical resident, MD, PhD, built already this crowdsourced conference summary. I mean, there's just a little bit of content. I have to go back and watch most of what I missed. But he's already put together the good start of every single session with images and notes. So if you go to that QR code, you can add to that crowdsourced document and share it out. And others who want to kind of add to it in any sort of number of ways. I think we'll also create a WhatsApp group and other elements to stay interconnected. But here's one element, an idea of how to interstitialize the content and community.
Yeah.
So.
And on that, this is a powerful stage. There's a big, broad community that we're reaching, and these ideas and this work is really important. So absorb the ideas, but more importantly, think of 3 people that you know, like, I know somebody who needs to know this. This work does not move without people behind it, supporting it, amplifying it, people standing beside, supporting it, and people standing in front of, providing protection and political cover.
And one thing you saw from Tony Young and the NHS Clinician Entrepreneurs, they started coming here, Tony did a decade ago, and the ripple effects of things that you can't predict.
Yeah, and he credits, he said, because I came here, the Clinician Entrepreneur Program exists.
Oh, she's crazy.
I know.
So don't underestimate the art of the possible and have a failure of imagination, because some of the cross
And who you might meet in line to pick up coffee,
Right. So anybody have ideas on what we should be doing next with NextMed Health? Don't be shy, and also share them asynchronously. Because we want to, again, NextMed Health is not meant to be just once a year at the Hotel, but a bit of a continuous hybrid platform for innovation.
Set of conversations and lunch. Dr. Canada.
One other quick thought was NFTs, community tokens, things like that. Just ways to facilitate more connection, more layers of engagement. Just a thought.
Okay, you're leading that up. Awesome. You're assigned.
Love it.
Volunteered.
Oh, Addison. Hi, dude.
Hello. Hi, everybody. Feel like the old dude because I've been here for so long. I've known both of you for a while, and definitely want to help you celebrate the moment. How about I'm going to take, of course, all this content back, but we're going to have what I'm thinking called a mini med, and within my organization, because again, I'm a payer. We interact within the market in a variety of different ways, but our clients are very interested in understanding the large accounts. When they consume benefits and care from us, how are we doing things? So I was just thinking we're going to have a little version of this so that we can share out information. It would be great to be able to connect and then feed back the reaction to that to you all as well.
Yeah.
So
Fantastic. And as a payer, and you've got the opportunity to take many of the things you've learned here and catalyze them in. It's all about incentives, and you guys often drive the incentives. So
absolutely,
a lot of what we saw in the Innovation Lab will hopefully be in your armamentarium.
Yeah.
Absolutely. Congratulations again.
Thank you.
That's fantastic.
Well, I'm noticing the clock.
Yep.
We need to stick to it. But again, I just want to say our hearts are full, and I hope yours are as well. So thank you. And let's bring on our next group. I will leave it to you to do the intro.
All right. In the home stretch, I think this is where the crux of a lot of this has happened. It's, you know, we've used the term from hospital to hospital, from primary care to virtual care, and a key element, of course, is the world of pharmacy. And one of our core faculty who's started here as a participant and has been faculty many times is Kevin Sneed. He's a good friend and also the dean of the USF College of Pharmacy, who's been really reimagining pharmacy, and he's going to give us a taste of what he's been doing and where he sees things going into the future. Kevin.
NextMed Health, how you doing? Well, first of all, I want to thank all of you for hanging in there on the very final day, down to the last minute. I'm going to have a very exciting presentation for you here in just a moment. I heard in the comment during the break, a pharmacist. They were asking who was that? Are they still here? Oh, she's right there. Are you a pharmacist? Okay. Well, hey, let's have a conversation. Well, anyway, several years ago, I had an opportunity to really delve into and start the pharmacy of the future. And most importantly, I really began thinking, you know, having come here about 10 years ago, I've been coming for 10 years, I really began thinking, how can we reimagine what pharmacy can be and what it should be? As a dean of pharmacy, I'm trying to get to the next level, the next generation of pharmacists. And so what you're looking at here, right here in the United States, we have about 5 billion prescriptions filled a year. But in reality, it's really far more than that, because embedded in that number are 90-day fills. So we're probably filling close to 6 billion prescriptions a year here in this country. So again, back in 2014, I had the opportunity to start what I called at the time the pharmacy of the future. And it was really exciting. A pharmacy had been there before. They were very traditional. And when they approached me, I said, you know, I think I want to do something a little bit different. And so this was my idea back then in 2014 of what the pharmacy of the future should be. Now, what you're looking at is a rendering that we developed at the time with the architectural team. And quite honestly, even, you know, all these years later, I still have not seen anyone kind of mimic. I thought by now this would be, you know, ubiquitous in Walgreens and CVS. They would have stolen the idea, but they haven't. But I would argue that if you look here, there are still 3, 4, maybe even 5 elements that if you walk into any pharmacy right now, you're not going to commonly find even today, that we are commonly doing. And by the way, this is a fully functioning pharmacy that is open right now. But I started off with making sure that we mapped out everything according to a zone and a process. I wanted to really think about what should be occurring and what can we gather from the common commerce and put into that location. And so you all see things that even back in 2014 and 2015, we were talking about big data, the Internet of Things. You know, we began displaying all the mobile and wearable apps on the wall. We weren't selling it, but we wanted to socialize the idea. And then in the lower right corner, patient engagement. I'm going to come back to that in just a moment. So here's an actual photograph. And one thing you will notice, we did not do any straight lines. We tried to stay away from straight lines. When people walk in, I wanted them to feel something different. I wanted them to have a visceral feel. I commonly believe that you don't have straight lines in nature. And I think that we are wired to actually feel and experience that. And so here's one photograph, and then here's a second one. And so along the way, I ran into this guy, Daniel Kraft, and we became friends. And so he invited me to come back in 2015 and talk about the pharmacy of the future right here on this very stage. And back then, we were exponential medicine. But now, what had been the future is now common. Our students have been going through there for years. What are we going to evolve into next? What is going around in the mind of someone like a Kevin Sneed? And so now I'm introducing to you the very next thing that we're going to get into, the evolution of everything that you saw before. In just a moment, we're going to start here on the left and kind of work our way around. But we're taking a very similar mapping process that we did before. And so here are the elements that we're actually going to plan to implement now into that very same location. And now what's happening is quite funny. I just got a text right before coming on stage about, and I won't say which team, but they're saying, hey, there's a professional team in Florida that now wants you to bring this pharmacy into their location. Do you have any interest? I'm like, yeah. Well, I wish Tom Brady was still around. But in any event, we're going to start here in the top right and then work our way around. An omics lab, 3D printing, and telehealth avatars. All of you really heard the really compelling conversation we had with Alistair Martin. And so I see a brand new role for on-site pharmacy research, holographic data, and then we really want to make sure that we're being available for our patients. It's really important to understand, how many people remember Y2K? Remember we were going to shut down, the whole world was going to shut down, remember that? Well, guess what? Now we're about to be in the second quarter of the 21st century. And I couldn't be more optimistic than anything that we have going on. So again, just to kind of bring your attention here, and in just a moment, I want you all to really also pay attention to the Iron Man holographic. I didn't put it in bars, but I really want to bring your attention there. But all of you recognize this here on the matrix, the red pill or the blue pill. Well, eventually, I want that patient to come along and say, red pill or blue pill. Well, what did my pharmacogenomics say? Did it tell me which one I should take? And I want Morpheus to say, you know, I think you need to go talk to your pharmacist. And so what we are developing in our college right now is a whole group, entire groups, an entire class. We are bringing about what we call the molecular clinical pharmacist. We put pharmacogenomics and just genomics in general into the curriculum so we can train entire cohorts. That's one thing that we have not done in the educational system at all. Many people still today don't know. They want to order it, but then they hear, well, after I order it, what do I do with the information? Well, we're going to take care of that challenge, and we're developing that right now. If any of you have been to Disney World, or if you have children, and you can, and they go and they get that big tube, and they just sugar themselves into oblivion, okay? Well, I took my children back in 2012, that's a very important part of the story here, to Disney, my son's 13th birthday. And when it was time to go, my wife said, okay, let's go. And I said, wait a minute. And she kept saying, Kevin, let's go, let's go. And I said, wait. And I must have taken 20 pictures of people walking up and getting that candy, because what I saw were people coming up and getting medication. I said, what if that were medication in there? And what if we could personalize the medication back to the individual patient? And what if we had 3D printing? And so I was pondering about this, and then I said, you know what? Nobody in the entire world is talking about doing 3D printing. And I was putting a little team together, and I talked to our engineering college. Lo and behold, some guy that we all know had already done it. But I couldn't have been happier, because when he and I talked about it, I said, I want to be one of your locations, and let's talk about 3D printing, and we can match it with pharmacogenomics and personalized medicine. We can improve adherence. We can actually create a brand new value proposition for all of our patients. And so, again, coming back here, now I'm going to bring your attention to the top right corner. In that very location, we were doing telehealth before people were calling it telehealth. We were already communicating with patients back and forth in that little video room up in the top right. But then I came here in 2019, and my very good friend, Chris Hillier, began talking about digital humans. Now, this is from 2019.
The skill I am most excited about is patient activation. Imagine if technology like me could be used for better outcomes and experiences before, during, and after professional care. Not only can I help patients and their families, I can also help the healthcare team.
And that was the moment that he had me. I can also help the healthcare team. I began imagining, what if we could get that digital human and put it into our pharmacy environment, and when people really want to walk away, and we can have AI in the background talking with the patient, and we can gather data about their challenges. Is the medication working? And that whole idea about medication working really began to make me think, what should the role of the pharmacist in the 21st century, in the second quarter of the 21st century be? I'm sorry, I know it's a busy slide, but pay attention to the bulleted points here, the large bullet points. My vision is that pharmacists must get beyond being purveyors of product, okay, where we're simply dispensing product to a patient. And we must now engage as part of a healthcare team, a patient-centered approach, where we are measuring and monitoring the effectiveness of the medication that's given. That should be the new role, and that's what we're training our current pharmacy students to do. I'm developing a process right now called prescribing a drug, prescribe an app, and prescribe knowledge. When the medication comes into the pharmacy and the patient comes to pick it up, they should automatically get all those tools right there that we've been talking about for years. They should automatically get a fitness tracker and a Bluetooth blood pressure cuff, a CGM. It should be automatic. And we shouldn't have to worry about who's going to pay for it, because what we're really paying for is the data that we're going to gather from it. And then here again at the very bottom, we want to make sure that we're going to build an ecosystem around the patient with blockchain and interoperability so that now the patient controls their data. I talk to far too many people now where they have too many portals, they have too much information. So, very quickly, the pharma in the clinical surveys, pharmacy locations all over the country, people are walking in, we collect no data. I think pharma should come in to every pharmacy, about 28,000 in the country, and we should collect data and do surveys, and we should use that location as a patient, clinical patient information location. Here are some of my patients. Okay, even though I'm a dean, I still have patients in the clinic. You all can see one of my patients here, Darth Vader. He's always out of control. He's always upset about something, threatening everybody. But the actual fact of the matter is, we need to map what's going on with him back to the medications and have AI in the background trying to figure out why is he not improving. Simply giving people a medication doesn't mean the medication worked. It doesn't mean that they're even taking the medication. We have to do far better than what we've done. So I'm working with a company, again, my friend down here, a Canadian company. I'm working with them right now, MMHG, to build an AI-driven platform. Now, they already have the platform, but they contacted me. They said, well, we don't understand why more pharmacists aren't adopting our platform. I said, give it to me, and I'm going to help you out. So we're starting a pilot project with them right now, and I'm going to be pushing them to put more AI in the background. And so just a moment ago, just to kind of speed up.
To keep up with those changes, both pharmacy and pharmacists have had to do the same. Technology and entrepreneurship is where we plan to include virtual and augmented reality, a multi-taction video wall, CAD drawing software, 3D printing, and holographic technology for virtual collaboration. Envision a space where students, faculty, and staff, and community partners can come together and collaborate. It is now the pinnacle of the pillar of pharmacist career opportunities and reshape the future of pharmacy and healthcare.
So the number one thing that I wanted to do is make sure we built a platform that would allow our students to actually be able to learn everything I just talked about. And it's working. By the way, we talk about in entrepreneurship and doing a pitch. We actually develop, we don't have the Shark Tank, we have the Bull Tank. And we had 2 groups win a statewide competition already as part of our iTech Academy. And then finally, I just want to make sure, it's not good enough to really give access for all this information and all these technologies. We have to work harder. We cannot lose the human touch. We have to work harder for adoption. We all know about social determinants of health, but now we really need to focus, all of you here need to focus on the digital determinants of health. And we are partnering with Tampa General Hospital to bring the hospital into the home. But the most important thing that they did here was look at the people that they have, that they're showing in the advertisement. We want to make sure that everybody feels welcome. We want to make sure that people have the adoption of that and not simply that we're providing something they're not ready for. And so finally, the number one thing that we have to overcome is interoperability. We have to make sure that all the information we collect in the pharmacy can be shared, and we need to be able to pull information from any environment. Again, blockchain is going to be a very critical part for the future of pharmacy at 28,000 locations around the United States. And so with that, thank you all very much. Thank you for hanging out with me. I hope I inspired you.
Amazing work. It's great to see the evolution. Just real quickly, what do you see with all these new tools, AI, ChatGPT, the future of the role of the pharmacist?
You know, the future role of the pharmacist really is going to be, you know, making sure that we are hitting the patient outcome that was intended for the medication to begin with. Every medication problem may not be a medication problem. It may be a social problem. You know, we may need a social worker. We may need a dietitian. We may need a lot of different things, but we have to make sure we're engaged in not simply giving medication out to people, but also making sure that when we give it to them, that it's achieving the outcome we want.
100%. Thank you, Kevin. So pharmacy is going somewhat physical and phygital, but also that is of primary care in many other fields are shifting from physical to digital. And I am a pilot, and I learned to fly in the Brown University Cessna 150, $20 an hour back in the day, and that was what the cockpit looked like, pretty analog, hadn't changed for quite a while. I later, thanks to Pat McGinnis, who's here, ended up joining the Air National Guard and got a bunch of fighter jet time in the back seat as a flight surgeon, and recently started flying again because we weren't going anywhere else in the pandemic, and I've upgraded to a little faster bird, and I'm that kind of plane also started with round dials, but more recently has had a full glass cockpit, as you see here. And this is a plane I co-own with our next faculty member, Jeff Rutledge. You can see us here flying a few months ago. But what's amazing is to go from that analog world to have this whole new sort of touchscreen glass cockpit that gives us basically AI-enhanced, augmented vision, situational awareness at the tap of a finger, what used to be buried in a chart. So much safer, much more reliable, and it gives a whole new realm to flying. When some of that is coming to healthcare, some of it's coming to primary care, and Jeff Rutledge has been a pioneer in this net world of bringing healthcare to the virtual world, and is going to share some lessons he's learned in building that platform in HealthTap. Jeff.
Thank you, Dan. Well, hi. It's wonderful to be here on the last day and the closing out session for the wonderful seminar we've had for the last 4 days. It's been amazing to meet and connect with folks here. I'm going to describe how virtual health technology is transforming the way primary care is being delivered. But I want to share a little bit about how I got to this point. I'm a physician. I'm an internist and an emergency physician. I've practiced and taught medicine in academic and community settings. But I'm also a nerd, and my mission in life was to use technology to improve the way doctors and other healthcare professionals deliver care. So I studied computer science, and I got the PhD at Stanford. Then I got the faculty job, the tenure-track faculty at Harvard Medical School. I was at Beth Israel Deaconess Medical Center, and then I got the NIH award, and I built I focused on creating, using technology, creating models based on causal probabilistic knowledge-driven models combined with numeric simulation models of cardiopulmonary physiology, built a decision theoretic treatment planner for patients in the ICU based on optimizing a multi-attribute preference model. But in the end, I realized this system was not going to have a big impact, not going to reach very many people. And so I left my job at Harvard, and I came back and joined a fledgling startup at California. And this was in the era when the internet was new, and we wanted to use the internet to disintermediate all of the healthcare providers and make healthcare better. And although that initiative had some issues, one thing we did was we said we should make health information available to consumers. And I had the pleasure of building the first consumer health website at a company called Healthion. And you've probably heard of it because you know it today as WebMD. I subsequently went on to work at Hippocrates, where I was head of product and demonstrated that doctors would use mobile devices at the point of care to improve the way they delivered care. I put those two together when we created HealthTap back in 2010, based on this premise and this understanding that healthcare was going to be available on mobile devices, and we wanted to be there first. So it turns out the journey has taken us to the realization that virtual primary care can be delivered on our healthcare devices. We first implemented a digital urgent care service in all 50 states, 24/7, back in 2014. We had an interesting journey. We implemented that platform in many other ways. We did it in South Africa, we did it in New Zealand, we did it in England and Hong Kong, and we started in Australia, until we realized as a company that actually the value in virtual care was in virtual primary care. And what is it about primary care that is so important? And why is it that we're now on the cusp of a transformation of primary care to virtual primary care? Well, it turns out, as others have commented on this meeting already, that when you have primary care, when people have a relationship with a primary care doctor, they get more preventive care by substantial margins. They have dramatically higher confidence in things like vaccines, almost double the rate of vaccine confidence among people who actually have a primary care doctor that they know. And as has also already been mentioned, healthcare costs go down. One study is really quite remarkable, looking at, for each primary care visit, what the annual change in healthcare cost is, and some studies show more than $700 for each visit. But if you look at the high-risk patients, it turns out that a single primary care visit reduces healthcare costs by more than $16,000. And of course, as we've also commented, people live longer when they have a primary care doctor. It's quite striking. In the rural or underserved areas where there aren't enough primary care doctors, had primary care at the same level as are found in urban centers, that people would live on average about a half a year longer, which is quite striking. A report published just yesterday by FAIR Health, reported on an Axios, indicated that something like a third of all people who get health care don't actually have a primary care physician. And although we have a specialist for every problem, the reality is that it's the primary care physician that supports and encourages preventive health and actually leads to significantly longer life. So given the value and obvious benefits of having primary care, we would be focusing on this a lot, of course, wouldn't we? Well, no, it turns out we're not enough. There's a shortage, and the AFP says that over the next 10 years, there could be up to 48,000 too few primary care physicians. We're simply not paying enough attention, and the rural areas are hardest hit. There are places, healthcare deserts, where you just can't get care. There aren't any primary care doctors or other healthcare professionals available. And as a result of not having enough, workloads rising, and doctors' lives are being focused on being pushed to more productivity. Higher productivity means less time with your patient. This is not satisfying for doctors. It's leading to burnout and making it harder as doctors are leaving the field because it's so unpleasant, leaving more work behind for those who remain. So burnout is a problem in primary care. So it turns out that virtual primary care is at least part of the solution, maybe a big part of the solution to not having enough primary care. It turns out that virtual primary care is more convenient. It's actually as or more effective than in-person primary care for most people. And interestingly, it's far less costly to deliver healthcare virtually. And of course, when you have virtual care, it's equally available in areas that currently don't have access to sufficient primary care. And the most exciting thing for me is to see that how much both doctors and patients love getting care virtually. Some of this is counterintuitive. It turns out, though, that virtual care has many measured benefits. It improves adherence and follow-up to care compared to traditional office-based care. The concerns that there would be excess numbers of prescriptions written virtually have turned out not to be true. People were worried it wouldn't work for seniors, but it does. We see that the largest rising segment of users of the population, and even for people with dementia, when they have a care provider, they can still be guided to use virtual care from home. And again, the most important thing about virtual care is it actually leads to relationships of trust and caring. So virtual care is turning out to be just wonderful. And who are the doctors who are interested in doing this? It turns out that the doctors who most want to be the traditional doctors connecting with their patients and delivering longitudinal care over time with their patients are flocking to the service and finding it incredibly rewarding. Let me show you just one example. This is Dr. Koja Karu, one of the doctors on HealthTap. You know, she's a well-trained internist. She's got 20 years of experience. She used to be a hospitalist. She's worked in ambulatory care settings. She lives in Las Vegas and needed a more flexible lifestyle. In particular, her parents who are aging live in Romania. And she wanted control of her lifestyle and the ability to actually travel and take care of her parents when she needed to. So she works with us, and you know, whether she's at her home in Las Vegas or whether she's visiting her parents in Romania, her patients don't know the difference. She connects virtually over the internet with the server. Of course, all the data and security remains on the US server, but she connects to us from her location. Interestingly, you can tell from what people say about her how much she enjoys giving healthcare, and the reviews are stunning. I would invite you to actually go to HealthTap and look up at her profile. You can see the most recent in order, and you see I'm not cherry picking her reviews. They're all like this. It's just amazing. She was awesome. She's amazing. What a wonderful experience. Wow, she's amazing. She's treating me for multiple concerns. She's the best doctor I've ever had. She's treating me, it's remarkable to see what people say. I wanted to give you just a couple of examples to show you kinds of things that are actually happening in virtual care, which may be a surprise to some of you. These are cases I saw personally in my virtual primary care clinic. Here's a gentleman who showed up. He actually had already done an ultrasound of his leg. He's a contract worker, spends too much time sitting at a chair at home, developed pain and swelling in his leg, was concerned. He actually got an ultrasound and a D-dimer to measure the degree of clotting in his blood, and both were off the charts. The ultrasound, I appreciate, difficult to see here, but it shows clot in an enlarged popliteal vein. So I was able to start him initially on an oral anticoagulant, and he got better very quickly and was quite grateful to the process. He had no insurance, no access to care. He was afraid to go to the ER, and he had a problem that could have killed him. But as a result of getting appropriate therapy right away, he did very well. Here's another example that may surprise some and follows on our discussion about the care of diabetes. Jorge is a 44-year-old Hispanic gentleman who works as a driver for Grubhub. He lives in the Central Valley. He has no health insurance and quite modest means. He knew he had type 2 diabetes. He'd previously been placed on metformin and glyburide, and he knew he was worse. He felt bad. He was peeing a lot, hungry, dry mouth, fatigue. And he knew he had a problem. He was afraid. He didn't have enough money, couldn't see a doctor. So his partner convinced him to do a consult, and I met him on HealthTap. And after connecting with him and describing what was happening, generated enough trust that he was willing to start on insulin. And so we did this virtually via video. He got them supplies, and I taught him how to draw up and then self-administer insulin, and then managed his dose over the next few weeks. On HealthTap, once you connect with the doctor, you can send them text messages. So you can have free, unlimited texting between the doctor and a patient. The doctor gets to manage how that works. So I encouraged him to send me his routine blood sugar measurements, and we adjusted his dose. And over a few days, we got his blood sugar down. And as you can see from the chart, we achieved essentially normal blood sugar levels virtually with a gentleman at incredibly low cost compared to him, compared to what any other option might have been. And finally, I'll end with a comment on the last patient here. Janie is a very high-functioning 46-year-old Asian executive. She lives in the Sacramento area, actually commutes to work in the Bay Area. And she has multiple complicated medical problems. One of the most challenging and interesting internal medicine patients I've had the pleasure to take care of. And she read an article I wrote. It was entitled Myths and Misconceptions About Virtual Primary Care. And she sent me a note. She said, Jeff, you missed something. I want you to go and update that article. And these are her words exactly. She said, I want you to say that telemedicine can work for patients with complex medical history, because a PCP who's familiar with the patient's case can better prepare patients for specialty visits and be more effective at coordinating their care. So our patients are telling us this is working. Our doctors are telling us this is working. It's a solution that makes doctors happy, patients happy, and allows us to distribute primary care to all the places it needs to be. And so I make the point, and I'd like to repeat, that virtual primary care is in fact transforming the way primary care is being delivered, enabling the widespread delivery of a more convenient form that's more effective and highly affordable for healthcare. I put a link here to a set of sources, resources, and references that give you data around the various assertions I've made here today. I welcome you to look at it. There's actually a bit.ly link, bit.ly/virtual healthcare, which will give you the same information if you're interested. And with that, I'm done. I've described how primary care, the virtual primary care platform connects doctors and patients, and described how even without additional technology, it's possible to deliver a very high level of effective care. But once you have that connection, there's a whole variety of things that can be done to extend the scope of practice for virtual care. And our next speaker, Dr. Bill Charniak, a friend of mine, a fellow Canadian actually, is going to describe some of the ways in which you can use additional technology and capabilities to expand the scope of practice, delivering, measuring, and monitoring in the home, and also delivering treatments. Bill, would you like to come out? There we are.
All right, thanks, Jeff. Okay, so thanks so much to Dan, Shauna, and the organizers, and thank you to all of you. I'm sorry you all seem to be cursed to listen to me both before dinner last night and before the closing act today, but I'll try and move things along here. And so, as you heard from Jeff, I wanted to give him thank you for also introing into the importance of virtual primary care. And as he mentioned, what I'm going to try to do now is talk a little bit about how we can leverage technology, software, and then hardware devices in order to further facilitate the expansion of what doctors can do virtually. And so I'm going to talk to you, last night I gave the pitch and talked about a little of my background and how Rocket Doctor came to be, and I don't want to repeat too much for you now, but just as a brief sort of context, backgrounds in emergency medicine, as well as family practice and global public health. And I had this picture on the screen because the origin of Rocket Doctor and how we kind of came to be in this sense really begins in sub-Saharan East Africa, and the idea of utilizing advanced diagnostics in order to bring access to care to places that in some cases might lack running water and electricity, let alone physicians. And that was kind of the genesis of how we could start to engage these advanced devices, but actually bring them back home to a domestic setting. And then thinking about the experience in the emergency department, seeing lots of folks coming in that really I felt didn't need to be in an ER, could have been managed effectively in an outpatient setting. How could we marry the two together in order to improve equitable access to care and actually do more for less cost and improving the system? And so as we started to put Rocket Doctor together, and for all the folks that are part of systems here and other healthcare facilities, the key for us is really how do you put a system together that makes MDs the owners? And so a program by doctors for doctors, and that's the real ethos at Rocket Doctor, is how do we enable an independent physician to actually practice medicine virtually? And then how do we take all of those independent physicians and then combine them into a system of care, and in our case, predominantly direct them towards servicing a population on Medicaid, and then also folks in rural and remote communities. And so we've had some really interesting talks over the course of the last few days, and some of the content that was provided was looking at the cost of delivering care in the US healthcare system and breaking it down by, what do you get? What's your ROI for the money that's being spent in terms of outcomes for life expectancy and healthy living? And I think one of the things that interests me is the idea that we don't talk a lot about Medicaid. And yet Medicaid, I'll show you some numbers shortly, is responsible for about $600 billion of the $4.3 trillion healthcare budget, and it has about 90 million people. And so as we thought about, Rocket Doctor building our platform, the idea was how can we, again, direct towards this population? This is just a quick trip down memory lane to think about how, the expansion of Medicaid under the Affordable Care Act, and then how folks got access to virtual care for the first time at the start of the pandemic, and at least from the comfort of their home and not necessarily from a rural facility or FQ. And I think, this is a common thing I hear. Can they use telehealth? And some folks may have difficulty using services, certainly, but interestingly, in California, if you look at Medi-Cal, 64% of people on Medi-Cal are actually working. And so yes, for the most part, folks will have cell phones and can use telehealth. And so these are just some of those numbers that I talked about: $4.3 trillion cost, 600 billion, 90 million people. And now to sort of get back to the technology aspect and building on what you heard from the dean at USF, as well as what Jeff was talking about, the idea here is, we think about virtual care largely as an EMR with a FaceTime Zoom team equivalent bolted on. But that's really missing the power of using technology to not just recreate the in-person experience, but then go on and make healthcare better, and then enhance the confidence of physicians delivering that care. And so this is the way we sort of conceptually think about things at Rocket Doctor with some of the integrations that we have currently in the platform. And it kind of takes you on a schematic from start to finish on that patient experience. And that's the software side, but it includes components of hardware. And so you heard from the dean about the pharmacy of the future. And so the idea here as well, of course, there's there's lots of devices that have integrated services with different virtual care companies, but the thing to consider is how do you give the ability for a clinician to have access to that data in real time while they're talking to a patient? How do you ship those contents to a patient or have it available to them at home in advance of the medical visit? And then how do you integrate all that data together to then feed something back? And so this is a quick demo of digital otoscope integration. And the idea here is, as the actual physician, you're talking to a patient has an earache, they've been given a digital otoscope, they pop it in their ear, and you can direct them how to move it. You can, in real time, actually see the image. You can hit the button to record a picture, and then you can populate into your medical record, into your own physician note on the on-examination functions. You don't, sometimes doctors, we've got to draw these little things and try to pinpoint where the lesion is that you're looking at, but now you can actually just upload the photo directly in. So that's the idea. And then how do you take that a next level and use AI and machine learning to then identify, okay, what's actually being seen here compared to millions of other images, and then how can you feed that back to the physician for predictive analytics? And I think that's some of the future aspect. And then these are some of the early integrations that are a little bit more defined that I'm going to take a few minutes to walk you through. And the idea with this first one in the top left, smart patient matching, this is really what we focused on at Rocket Doctor, building ourselves. And the idea of this slide is something I mentioned last night, which is not every patient is appropriate for virtual care. And not every provider is competent or confident to see every patient virtually. And we sort of missed that as we were forced to jump into virtual care, where we forgot that actually in medical school and residency, we don't have defined curriculums for virtual care training. And so what we've done at Rocket Doctor is said, okay, we're going to ask a bunch of things to the patient, collect a bunch of data, and then we're going to ask the physicians for a bunch of things, collect a bunch of data, and then we're going to match the two things together in order to make sure that you've got the right doctor, but also the doctor has the right patient. So that you don't just say, well, you know what, I'm not sure, I got to send you to the walk-in clinic. And this is how we've started to push things forward, and I've got some stats on this outcome from some of these early experiences so far. And then I'm going to go through a few other of the early integrations that we've built with different partners that we work with at Rocket Doctor. And so, and these are all companies that you can work with as well if you're building platforms and sort of thinking about how to engage additional software and technology. So patient medical history service, there's Epic MyChart. There's a lot of ways that you can collect data before the patient comes in. What we partnered with here is a really cool company called First History that actually takes AI-driven patient intake where you can ask a complete history, chief complaint, and it walks the patient through all the questions the physician might ask. And then it can plug that data into the medical notes so that as we build that integration, the physician, when they log into the session, already knows all about you as a patient. Of course, that builds a huge amount of data on the back end, so then you can think about how can you start to inform the doctor as this is coming in, or even when you first log in to know more, compared to, let's say, millions of other patients that have been seen. And then clinical summary integration. So this is a common criticism is, well, you don't know anything about the patient that you're seeing. You're seeing them in a snapshotted window. Of course, with HealthTap and with Jeff's company and where you've got integrated primary care, you can follow them longitudinally virtually, but maybe the first visit you want to know, or a subsequent visit, well, have they been to the emergency department? Have they been to a walk-in clinic? Have they updated their patient profile? And so this company now can pull a summary from all the various EMRs and from central systems like Commonwealth and PureWell to present it to the doc, so you know more about your patient before the visit. And then this is really neat, and there was a company that pitched yesterday a different similar service, but really neat natural language processing where you just talk to the patient on the telehealth session, and then this produces a usable medical note for you. So if you're a psychiatrist and you might take an hour with your patient and you might spend all this time at the end of a clinic writing up all your notes, you don't need to do that. This will just generate it for you. And then, of course, on the back end, loads of data that you can also plug in and build into the system. And we work with a really neat company called Ambience Health that just came out of stealth mode not so long ago. And then you think about, this just shows you how it looks on the integration. So in our platform, when you're doing the virtual care visit, it can actually pop up the note for the physician as they're running through. And then language. Not everyone speaks English. So in fact, most people don't in the world. And so how do you enable the ability for patients to access a physician in a language they're most confident and comfortable with? We've got a really neat integration with a company, actually a Canadian company called Voice, that helps to organize 230 languages for folks. And then in California in particular, this state state is very progressive when it comes to Medicaid and social determinants of health. And folks here may or may not be familiar with CAL-AIM, which is some of the new legislation that came out where a physician can essentially write a billing code for a community health worker. Really neat. So now, you see a patient as a physician who maybe has issues with social determinants of health, so housing, food, transportation. You can actually, we have an intake form where folks can answer those questions before they log into the session. And then after the visit, the physician can, send a referral off to our partner Pair Suite, and then they can get access to those services with a CHW that's funded by Medi-Cal. And then just to take us sort of back home before I close, the idea here is, okay, we've got this platform, we've got the docs that have agreed to accept patients on Medicaid. What do we do with it? So we've turned, really with this global public health approach to community-based organizations and said, hey, you got a bunch of your members who have insurance, should be able to see a doctor, and yet no doctors will accept that insurance. Here you go. There's a platform with physicians that are ready to go. And so we formed a partnership with the Housing Authority for the County of Los Angeles. And these other folks, just sort of early, we've just started to do this since the fall, but are really excited about where this could lead for potential equitable access to care. And this was what I mentioned I was going to kind of close on here, which is just some data of outcomes. So more than 250,000 patients, more than 500 doctors who've been able to launch their own virtual care practices, great reviews from patients, 15 tech integrations. And then the key thing on these slides, lots of folks don't have a PCP. And now some of this data is from Canada as well, so you'll have to forgive me, it's a mix across border, but lots of folks don't have a PCP. People are using the service as a virtual primary care provider. And in the end, about 94% of patients did not need an in-person visit after their virtual visit. They were able to be effectively managed virtually. So that's where I will end. Thanks for listening to me. I appreciate it.
Had to come out and say, you are my people. Thank you. Thank you. He's got a question, but I just want to say, you are my people.
Thanks.
Thank you.
Well, we heard from the clinician entrepreneurs from the NHS this morning. What would be your 30-second summary of what you've learned as a clinician entrepreneur in the US, Canada, and globally?
I think I was chatting with Shauna about this behind the curtain here, that I thought I understood the healthcare system, and she corrected me, it's not a system, it's multiple systems in the United States, but I thought I understood it as a practicing doctor. I worked for Kaiser for a little bit as well in South Baltimore, and I realized I don't understand anything until I started Rocket Doctor and had to try to understand the payer mix and the difficulty of accessing care and how hard it is. And then also, seeing these, we survey every patient after their visits about how it went, and seeing the reviews from people on how hard it was to get a doctor. You just as a clinician, I think you just don't understand what's going on behind the scenes. So anyways. Yeah.
Don't cover that in medical school. All right. Yeah. Awesome. Thanks for great work. All right. To bring us home, we have a special guest, a very famous author from the 2020s, author of Experimental Man, and many other famous books. Here is the one and only journalist, author extraordinaire, David Ewing Duncan. Thank you, David.
Thank you, Daniel. Okay, you guys have actually lasted to the very end, and I think we should give you a big hand, and yourselves give a big hand, okay? This is it. 4 amazing days, and you guys are still here. I mean, that says something. Okay, so I have a confession to make as we wrap up here, and I did not get the clicker. 2 seconds. Thank you very much. I have a confession as we're winding up here. I am from the future, okay? And I've come back in time to tell you how you guys did here in 2023 and how it's played out in the future for us in 2073. By the way, there's still a NextMed, which I'll get to in a second, in 2073. But what's happened in 2073 is a future that, I don't know, some of us imagined, some of us didn't, but it actually turned out pretty well. And here's why. It's because of what we did here. We remember in the future, this week in March in 2023 as being very important and pivotal to creating a kind of world that we would like to create. I mean, not everything's perfect in 2073, a lot of problems. But there's so many things that we learn from this meeting and this era and the people that are working now. And so here we are, We all have this framed, it's an image, it's a meme, although we don't really have memes in the future. We have something new and different, which you all will discover when you go to the future. So this is a shout out back to 2023 about how you guys did. And I do want to emphasize that we still have NextMed in 2073. Daniel is still running it. And I'll let you figure out how he made it to 2073. He's still crazy and harried as it leads up to, and then he comes out on stage and still, is brilliant and wonderful. And, some of you all are still around. But we also have Daniel's great-great-grandson dancing at our own silent disco in 2073. So, still around. In fact, it was 50 years from now, last night, that we had our own silent disco at NextMed 2073. So I'm going to share with you just a couple of my thoughts over the last 4 days. And then I'm going to ask some friends who also have come with me in the future. And by the way, we just arrived. The time machine was a little messed up. We just arrived. So, we're going to be a little informal here about how we do this. But a few observations I had, as Daniel said, I'm a journalist and I write books, and a lot of my work has been around wellness, around molecular testing. How do we predict the future? How do we predict our own health futures? And it's always amazing after the big break of the pandemic and all that to come back and see how things I've been following, like Mike Snyder and Lee Hood, who actually I've been working with a little bit on his project, how these things incrementally. I mean, we always think of these great leaps forward, but the reality is that these are incremental, and having that little break. Having been to many of these meetings in the past, it's wonderful to see how there's change. I mean, there is some dramatic change, but often it's just hard work and progress, which I think, having been literally, I was at the very first Future Med way back when, and I've been to most of them since then. And just watching this play out over all those years has been quite extraordinary. But wellness was a big takeaway for me, and so many tools that you all are developing and our speakers were talking about that are really beginning to understand the human organism and how it operates on our amazing planet. And being able to, we've been blessed in evolution to be able to actually be planners. I mean, as far as we know, there aren't that many species that can see ahead like we can. We don't always do the right. Well, sometimes we know things are coming and we do the wrong thing anyway. But we do have that gift, if you will, and you see that played out here, both in the attitudes and the inspirations and in the technologies. The whole mental health issue, I mean, we had a number of talks about that. I'm writing about that and doing a lot of research on that at the moment, and that was very inspiring to see how many great minds, if you will, are trying to untangle that. And, we're going to be working on that for a while. And another aspect is we heard a lot about technology and, hardcore medicine, things like that. But we also heard a lot about human stories. And if you come to these meetings and you don't hear the stories behind why did they start that company? It's hard to start a company. It's a pain in the ass. And why did they do that? And why are we developing these technologies in the first place to take care of our loved ones? So big highlights for me were many of the stories that were told. And Paul Stamets was one of the big ones. And he's a guy, I'm a historian by training. And not Paul, that you've been around that long. I think he's still here. But but he has seen the early days of psychedelics when there was a lot of promise, and then it was shut down, like an iron gate went down, with the war on drugs. And he stuck with it. And we're seeing now this whole renaissance of this idea of a new type of molecule or compounds, molecules, plants, helping us out with a crisis that we have in mental health. But anyway, I could go on, but I would like now to ask 3 friends of mine who I brought with me in the time machine from the future to join me on stage. So you may recognize these people. I mean, some of them, they're present day. In fact, I think your present day version of yourself was just out here introducing me.
It was my clone.
Yeah, okay. And amazingly enough, he still dresses the same in 2073.
3D printed each day.
it was my grandmother, and these are my vintage clothing.
Okay.
Yeah.
Then does that go back?
We have really thought about saving the earth.
Yeah.
So all of those sustainable practices. And I'm so grateful to my grandmother for having given me that wisdom.
That's fantastic.
Yeah.
And by the way, this is a great message to carry into the future, that we need to be good ancestors. We need to be good grandparents, great-grandparents. And I think, many of us are thinking that way. But so I would love Andrea Katz, who you saw on the very first day. She's a futurist. She does all kinds of amazing things. And she is going to tell us her future self, which is right here. You saw her present self earlier in the meeting. She's going to tell us what some of her inspirations have been coming from 2023.
So 50 years ago, Andrea Katz was here talking about how important it was to get to Next. And it's been so inspiring that in these last 50 years, the seeds that were planted by the people that she met 50 years ago came true. So we talked about Envision. Unbelievable that today in 2073, all of us are being healed with a big sound bath that started with a aloe black idea that sound and music and medicine could blend. And so here we are. We walk in the room and we are already vibrating at a different frequency. It's amazing. So we have envisioned that based on aloe black. The next thing we did was we expanded. So it was amazing that Alistair Martin talked about new conversations and getting people to really vote and have new conversations with empowerment. And that's turned into a global movement where it's a conversation with doctors again, like in the old days. So 2073 feels like Marcus Welby, 20 whatever that was, 19 whatever that was. And it's because of those first conversations that now social empowerment is happening through our health, and it's all blended. We talked, as you remember, 50 years ago about this notion of building. And unbelievable that IKEA got together with Esther Dyson and David Eagleman and developed an Umwelt chair. And what it does is it senses what we need and it responds to it, and also brings in patient voices constantly. So we have a thread of what it is that people want to tell us, not just our diagnosis to them, but now, of course, as we know in 2073, we know what they want to tell us because of this Umwelt chair. It's amazing. Then we talked about engaging. And there has been a new network with Roblox that was empowered to start with Best Buy and Atrium Health. But then Roblox came in, and now children, including the great-great-great-grandson, are part of this incredible, we all know this because it's 50 years now, 2073, but children are part of the conversation to really help us understand how play and games and the way that they experience data is really important to health. And then the final thing, of course, as you know, is the activation. And so because we all connected 50 years ago and committed to this, the activation is incredible. And I have a Sarah Palin. We have turned a global network of hope immediately. As soon as we hope something globally, it immediately turns into action. So congratulations, 50 years back, all of these seeds were planted, and to the people here in the present, thank you for giving us a beautiful 2073.
Yeah.
Thank you. Yeah. Okay, Daniel Kraft of the future.
Well, it's great to see that the Hotel Del has been renovated to its original state.
Again.
And these new regenerative medicine drugs are incredible. So just, I think it was the blue pill. Take the blue pill. That's the lesson. I think the reflection on now 50 years goes fast, right?
Yeah.
Don't blink.
Seemed like it was just yesterday.
It does.
Do you remember that old guy, Bill Gates, what he used to say? We tend to overestimate what we can do in a short period of time and underestimate
what can happen in 50 years.
Yeah.
So let's not underestimate.
That old guy, yeah.
Some people were underestimating, but the people who came to NextMed Health 50 years ago didn't, and cross-connected and built the future faster. So congratulations to what you've done in the next 50 years.
Yeah.
Shauna.
So my grandmother would tell me all of these stories about when she would go to NextMed, and she would be listening to people like Aliyah Bhatia. And it really inspired her to think about how we're engaging the entire healthcare teams. And there was a point in time where everything was physician-centric. Everything was physician-biased. Can you imagine that? And instead, we see nurses and pharmacists and social workers and pastoral care. You guys all, those were seeds planted so that we think about healthcare in teams. And you know what? They also talked about when you vote and you consistently develop that habit, you start taking care of the planet. So when we take care of the planet, it also feeds all of the humans on there. So I'm really grateful for the inspiration that those people had to help us think about the policies and the systems. They told me about this guy named Stacy Chang, who talked about systems and how we need to incubate and all of those refugees, and instead of having entrepreneurs in residence, they created mavericks in residence. And they allowed those people to take those ideas and they supported them. They provided that political cover. And because of all of those things 50 years ago, we actually have this thing. They used to talk about like disparities in healthcare. Can you imagine? Can you imagine women not having rights to do and make choices about their body? So all of those, surprisingly, were voting issues. So I'm just so grateful, and my grandmother told me about all of those things. So I'm grateful for her pioneering spirit about all of that. And because of those things, those ideas and those seeds that were planted in people who were bold and daring and courageous and decent, we all actually have access and accessibility to help that is safe, that's quality, and that feels caring.
Incredible, Shauna. Shauna just found out we were doing this about 5 minutes ago, so that was pretty
50 years ago. She had
50 years ago in 5 minutes.
Stick with the script.
Yeah, exactly. Well, I hope you all, when you visit the future, because in the future we can go back and forth, which is kind of fun, that you have the things that inspired you on top of mind, and you can see all of the great work and how it bore fruit. And even 100 years, 200 years, I mean, like I said, we need to be good ancestors. Okay, that's what the whole point of this is. And I think here in this room, that's what we're devoted to. I certainly am. I know all of us on stage are. And, it's almost about stewardship. And our good friend Maya Lockwood has been working on a project on stewardship, and she couldn't be here. But it's thinking not the next quarter, not, instant gratification, but how are we building, humanity and a planet that we will be proud of in 50 years. So I think we need to let you guys sign off here.
Well, and with that, since we're 50 years in the future, you thought 2023 was good? Just wait till 2024, NextMed Health. So make sure you get there. It gets better.
It gets better.
So with that?
Yes, just thank you, and please enjoy the view. Thank you for the Dell. Thank you for this historic, and thank you to you, and thank you for our online audience and all the rest of our team. Travel safe. And
see you in the future, near future.
We will see you next.
Thank you, guys.